I don't know. It's alphabetical, right?
To look up the names.
All right, you're
In the middle.
you're on that end as well. Name tag down there. I have Dr. Herman and Rita. Okay. Oh, you need me to?
Yeah, I need your PIV card.
It's in there.
PIV number.
Can you do the control?
Yeah, I know. I know.
I'll punch in the code real quick. If you do the control alt delete for me. There we go.
You pay for the vaccine, then it's penicillin. Every antibiotic, if you were looking at the antibiotics within some form, they would question whether they would actually, because the implement value is
Yeah, okay. Take these questions for FDA and for CMS.
Same thing in my opinion. FDA has gotten these technologies like cardio
Apologize. Okay. Apologize.
Check, check.
not approved. With cannabis.
I need your PIV number again.
yeah, I was going to say, I had intention of sharing with them.
Okay.
Okay,
Yeah, because the people, some of the people are asking about Wi-Fi and how to connect. I watch your back. I sat them. Oh, okay. All right.
This is great.
This is trip. Oh, Maria hasn't done nothing. I don't know what I've done, but okay. Just sit there and do what you do. Yeah. Now we're going to start having people have a seat.
We are going to start the meeting. Please take your seats. Thank you.
Man, take anything else off. Man, we don't have time for security rushing in. Good morning and welcome, committee chairperson, acting vice chairperson, members, and guests. I am Maria Ellis, the executive secretary for the Medicare Evidence Development and Coverage Advisory Committee called MEDCAC. The committee is here today to discuss recommendations regarding what health outcomes in studies for heart failure treatment technologies should be of interest to CMS. The following announcement addresses conflict of interest issues associated with this meeting and is made part of the record. The conflict of interest statutes prohibit special government employees from participating in matters that could affect their or their employer's financial interests. Each member will be asked to disclose any financial conflicts of interest during their introduction. We ask, in the interest of fairness, that all persons making statements or presentations disclose if you or any member of your immediate family owns stock or have another formal financial interest in any company, including an internet or e-commerce organization that develops, manufactures, distributes, and/or markets, consulting, evidence reviews or analyses, or other services related to the treatment of heart failure or mitral valve regurgitation. This includes direct financial investments, consulting fees, and significant institutional support. If you have not already received a disclosure statement, they are available on the table outside of this room. We ask that all presenters please adhere to their time limits. We have numerous presenters to hear from today and a very tight agenda, and therefore cannot allow extra time. There is a timer at the podium that you should follow. The light will begin flashing when there are 2 minutes remaining and then turn red when your time is up. Please note that there is a chair for the next speaker, and please proceed to that chair when it is your turn. We ask that all speakers addressing the panel please speak directly into the mic and state your name. For the record, the voting members present for today's meetings are Dr. Alan Hirsch, Dr. Salvador Cruz Flores, Dr. Michael Fish, Dr. Fred Kobolars, Dr. Marcel Salive, Dr. Art Sadrakian, Dr. Jody Siegel, Dr. Julie Ann Swain, and Dr. Diana Zuckerman. A quorum is present and no one has been recused because of conflicts of interest. The entire panel, including non-voting members, will participate in the voting. The voting results will be available on our website following the meeting. I ask that all panel members please speak directly into the mics. This meeting is being webcast via CMS in addition to the transcriptionist. By your attendance, you are giving consent to the use and distribution of your name, likeliness, and voice during the meeting. You are also giving consent to the use and distribution of any personal identifiable information that you or others may disclose about you during today's meeting. Please do not disclose personal health information. In the spirit of the Federal Advisory Committee Act and the Government in the Sunshine Act, we ask that the advisory committee members take heed that their conversations about the topic at hand take place in the open forum of the meeting. We are aware that members of the audience, including the media, are anxious to speak with the panel about these proceedings. However, CMS and the committee will refrain from discussing the details of this meeting with the media until its conclusion. Also, the committee is reminded to please refrain from discussing the meeting topics during breaks and at lunch. If you require a taxi cab, there are telephone numbers to local cab companies at the desk outside of the auditorium. Please remember to discard your trash in the trash cans located outside of this room. At 10 a.m., there will be a shelter-in-place exercise conducted here at CMS. It will be announced over the CMS public address system. This will not affect us, so we will continue with the meeting. So when it comes on, just keep moving. Don't move. Just stay in your seats. I'm sorry. Just continue with the meeting. Don't move. Stay in place. And lastly, all CMS guests attending today's MEDCAC meeting are only permitted in the following areas of CMS single site: the main lobby, the auditorium, the lower level lobby, and the cafeteria. Any persons found in any other area other than those mentioned will be asked to leave the conference and will not be allowed back at CMS property again. And now, I would like to turn the meeting over to Dr. Joseph Chin.
Thank you, Maria, and good morning. So we'd like to welcome our panel, our invited speakers, and our guests to CMS. We thank you for your participation on a topic that's very important to our Medicare population, given the prevalence of this condition. So I think we have a very interesting agenda, and I think we should proceed. So I'll turn it over to Dr. Rita Redberg, our chair of the MEDCAC.
Thanks very much, Joe. And I just want to add my welcome to all of the guests, the new panel members, the returning panel members. As Maria noted, we do have a full, and we'll have a very interesting discussion today, but in the interest of letting everyone, because we want to hear what everyone has to say, one of my roles will be to make sure we all stay on time so that we'll follow the schedule, and we'll try to follow that exactly. So I think we'll start now and just do introductions of all of the committee. Again, I'm Rita Redberg. I'm a cardiologist at the University of California, San Francisco, and I have no conflicts.
My name is Alan Hirsch. I'm a professor of medicine, epidemiology, and community health at the University of Minnesota Medical School, and I have no conflicts to report.
I'm Salvador Cruz Flores. I'm a professor and chair of neurology at Texas Tech. I'm a member of the panel. I don't have conflicts.
My name is Michael Fish. I'm a medical oncologist and a palliative care physician. I'm the National Medical Director of Medical Oncology with AIM Specialty Health, which is a subsidiary of Anthem Incorporated, and I work at MD Anderson Cancer Center as a clinical specialist.
You need to state if you have conflicts.
I have no conflicts of interest other than employment with AIM Specialty Health.
Thank you.
Yeah, hi, my name is Fred Kobolars. I'm a academic geriatrician at Robert Wood Johnson Medical School. I have no conflicts of interest.
Good morning, I'm Marcel Salib. I'm a medical officer at the National Institute on Aging, part of the NIH, and I have no conflicts.
Good morning, I'm Art Sidrak. I'm from Weill Cornell Medicine. I'm a professor of healthcare policy and research, and I have no conflicts of interest.
I'm Jody Siegel. I'm a professor of medicine, health policy, and epidemiology at Johns Hopkins University, and I have no conflicts.
Julie Swain, cardiovascular surgeon, vice chair of the Department of the Mount Sinai School of Medicine in New York. No conflicts.
Diana Zuckerman, president of the National Center for Health Research, trained in epidemiology and psychology, and I have no known conflicts of interest.
Mylene Sheesh, I'm at the Cleveland Clinic. I'm a heart failure transplant cardiologist, and I have no conflicts.
Lynn Warner Stevenson, I'm a professor of medicine at Harvard Medical School, director of the heart failure program at Brigham and Women's Hospital, one of the PIs of the Intermax VAD registry. My division receives research support from Novartis and St. Jude, and I'm an unpaid consultant for St. Jude and Medtronic.
Good morning. My name is Adi Renbaum. I'm the industry advisor
representative. I work with a variety of medical device companies on issues of coverage and payment, although I don't work with any heart failure companies at this time, so I have no conflicts.
I'm Elise Berliner, the Director of the Technology Assessment Program at the Agency for Healthcare Research and Quality, and I have no conflicts.
Good morning. I'm Patrice Stavine-Nickens. I'm a medical officer with the Heart, Lung, and Blood Institute, and represent the Institute and are very interested in research outcomes.
Clyde Yancey, Professor of Medicine, Professor of Medical Social Sciences, Chief of Cardiology at Northwestern University, Chicago, and Chair of the U.S. Heart Failure Guidelines. I have no conflicts.
And good morning, Bram Zuckerman, Director, FDA Division of Cardiovascular Devices. No known conflicts. Thank you.
Great. So next, it's my pleasure to introduce Dr. Daniel Canos from CMS, who will do the presentation and voting questions.
Good morning. My name is Daniel Canos, an epidemiologist in the Coverage and Analysis Group. Currently, assessment of medical technologies are made with some evidentiary questions remaining with respect to the clinically meaningful health outcomes for Medicare beneficiaries. Ascertainment of clinically meaningful health outcomes are essential for the CMS assessment of research studies of heart failure treatment technologies. Given the increased focus on the need of patients for new and innovative medical products, medical technologies are receiving market authorization based on less long-term data with greater reliance upon intermediate and surrogate outcomes. Innovative heart failure treatment technology studies are increasingly utilizing endpoints described by the FDA Expedited Access Pathway Guidance for market authorization, including intermediate endpoints such as exercise tolerance and symptoms, heart failure hospitalization rate, surrogate endpoints with pathophysiologic pathway leading to the clinical outcome. In 2012, recognizing the lack of consensus within the scientific community regarding the optimal endpoints for heart failure trials, the Heart Failure Association of the European Society of Cardiology convened a group of heart failure experts to evaluate the challenges of defining heart failure endpoints in clinical trials and to develop a consensus framework. Additionally, the International Consortium for Health Outcome Measurement, ICHOM, organizes global teams of physician leaders, outcomes researchers, and patient advocates to define standard sets of outcomes per medical condition and drives adoption. They have recently released a report on standard heart failure data collection sets. The European Society report summarizes the group's recommendations for achieving common views on heart failure endpoints in clinical trials. It also outlines areas of consensus as well as those which need further research. ICHOM created a standard set for heart failure pharmacotherapy, invasive therapy, and rehabilitation, including a focus on patient-centered results, internationally agreed upon methods for measuring each of these outcomes, including baseline conditions and risk factors. High-level treatment variables were also included to allow stratification of outcomes by major treatment types. And it also included a comprehensive data dictionary along with scoring guides for patient-reported outcomes. Shown here is the ICHOM standard set for outcomes, which includes patient and clinician-reported functional assessments of NYHA class and KCCQ, patient-reported psychosocial outcomes, also a critical evaluation of the burden of care, including side effects, treatment complications, total hospitalization readmission, and survival. Building off this work and other work cited materials which appear on the MEDCAC website, this MEDCAC panel will advise CMS about the ideal health outcomes in research studies of heart failure treatment technologies and appropriate follow-up duration to ensure transparency of national coverage analyses and requirements under coverage evidence development. We'll be hearing a clinical perspective from Dr. Ileana Pina, followed by the industry perspective from Dr. Philip Adamson, After that, we'll hear a clinical perspective with a focus on the use of functional assessments and quality of life measures from Dr. John Carroll. And finally, we'll hear from the Patient-Centered Outcome Research Institute's Dr. William Lawrence. In the afternoon session, the panel will vote and provide additional discussion on the following questions. An important note on the first question is that CMS recognizes the importance of mortality as a meaningful primary health outcome of interest in research studies. We are seeking input on what additional outcomes should be considered, as noted in the asterisk. With that in mind, how confident are you that the following are standalone, meaningful primary health outcomes in research studies of heart failure treatment technologies? In A, heart failure hospitalization. B, heart failure hospitalization or heart failure hospitalization equivalent events, i.e. outpatient IV therapy for heart failure. C, total hospitalizations. To answer this question, we'll use the following identifying scores for the level of confidence, with a score of 1 being low or no confidence, and 5 representing high confidence. Discussion for question 1. For health outcomes with greater than or equal to intermediate confidence, greater than or equal to 2.5, please discuss the appropriate length of follow-up post-heart failure intervention for assessing this outcome. Please discuss important considerations when assessing the merits of composite outcomes in research studies of heart failure treatment technologies, which include the combination of mortality, heart failure hospitalization, or heart failure hospitalization equivalent events. Voting question number 2. How confident are you that surrogate and intermediate endpoints are predictive of standalone, meaningful primary health outcomes, e.g. reduction in mitral regurgitation, cardiac remodeling, ejection fraction, or biomarkers in clinical research studies of heart failure treatment technologies for A, heart failure with preserved ejection fraction, B, heart failure secondary to mitral regurgitation where the focus of the therapy is mitral valve repair replacement, C, heart failure with a reduced ejection fraction, e.g. cardiac remodeling, ejection fraction. Again, we'll be using the scale below, identifying the level of confidence with a score of 1 being low or no confidence and 5 representing high confidence. Discussion questions under 2 are, if greater than or equal to intermediate confidence, greater than or equal to 2.5, please identify the specific surrogate or intermediate endpoints and associated disease or therapy which you believe are sufficiently predictive of meaningful health outcomes. Please discuss how these intermediate and surrogate endpoints meaningfully contribute towards the evidence base for heart failure treatment technologies. Please discuss important factors to consider when assessing the utility of surrogate and intermediate endpoints. Voting question 3. How confident are you that quality of life measures, e.g. Kansas City Cardiomyopathy Questionnaire, Minnesota Living with Heart Failure Questionnaire, are adequate measures, A, adequate measures which reflect the patient experience, B, should be included as the standalone meaningful primary health outcomes in research studies, C, should be included as a composite standalone meaningful primary health outcome in research studies, using the below score scale for identifying your level of confidence, with a score of 1 being low or no confidence and 5 representing high confidence. Voting question number 4. How confident are you that functional assessments, e.g. 6-minute walk test, VO2 max, ventilator threshold, A, are adequate measures which reflect the patient experience, B, should be included as a standalone meaningful primary health outcomes in research studies, C, should be included as composite standalone meaningful primary health outcomes in research studies, using the following score, again, identifying your level of confidence, with a score of 1 being low or no confidence and 5 representing high confidence. Discussion questions for question number 4. Please discuss whether additional patient-reported measurements, e.g. short form 36, Euro QOL 5 dimensions questionnaire, should be considered to capture burdens associated with the heart failure therapy under study. Please discuss the appropriate length of follow-up post-heart failure intervention for assessing patient-reported measurements. For some studies of heart failure treatment technologies, it may not be practical for patients to be blinded. Please discuss the impact of unblinded study participants on patient-reported measurements and functional assessments. Please discuss how to best consider the impact of adverse events associated with heart failure technologies while balancing the potential for improvements to meaningful health outcomes. Please discuss how to balance the benefits and harms of therapies which may improve near-term patient-reported health outcome assessments or clinical measurements, e.g. 6-minute walk test or symptoms, but may decrease length of life. Additional discussion topics include, please discuss how health outcomes of interest and appropriate follow-up duration in studies of technologies designed for diagnosis of acute decompensation of heart failure. With the health outcomes and information that we have discussed today, how confident are you that there will be enough accurate information provided to patients for them to make informed decisions? Please discuss how studies can be designed to accurately capture patient preferences and how their preferences can be best considered and operationalized once the study has concluded. Thank you.
Thanks very much, Dr. Caños. Next, I'll introduce Dr. Ilyana Pina, who's a professor of medicine, epidemiology, and population health at Albert Einstein College of Medicine and associate chief of the academic affairs at Montefiore, to talk about, give us the clinician's perspective. Ilyana.
Good morning, everyone, and I want to thank CMS and the panel for asking me to be here. It's quite an honor. These are my disclosures, but I want to make sure some of you identify me as a consultant for the FDA. Today, my comments are purely my own as a clinician, and I do not represent anybody but the clinical community and something that we do every day. So I've been doing heart failure transplant for over 20 years, and at my institution, we have 2,500 admissions for heart failure a year. So is it a problem? The answer is yes. So Daniel gave me a long list of things to do. These are basically what he just reviewed, but it's a little bit daunting. So I thought I'd start with having the patient in front of me and asking the question, what makes me happy and what makes the patient happy? And I think probably what makes me the happiest is when I look at the patient and I see that the ventricle is actually getting better, which translates to I don't have to give them an ICD, which means I've probably medicated them well enough that they feel better and are doing more, and that's my happiness. What makes the patients happy is when I walk in, I say to them, your heart looks better, and you don't need the ICD. And now maybe I can stretch out your visits, and maybe I can cut back on some of your, what I call the junk medicine. My patients know I call it the junk medicine, and then the important medicine. But when I put all this together, we really have arrows for everything. What makes them happy and what makes me happy may be the physiology and their interpretation, but they're pretty much the same goals. And keeping them out of the hospital is a huge part of my goal. I don't like the patients in the hospital unless there's some patients that are absolutely necessarily having to be in the hospital, and that is a lot of our population today. And I think we forget, we treat the admission in the hospital as if it were this whole separate thing, and it's really a comma in the whole care. And that's how the patients see themselves. They see themselves as moving through their disease process, and these are time periods, but we seem to categorize them as all this separateness. It's the same thing, it's the same disease. Doctors, but don't have a lot of experience in the heart failure world. Once you put them into bed, and Clinton Bronner today is going to talk about that, they lose function. It doesn't take long to lose muscle function. Now all of a sudden somebody who was functioning at home has to go to a SNF because they can't go back home again. They're not rehabbed enough. We're not doing good physical therapy. We're not sending the patients to cardiac rehab. And so the length of stay business, which has been threatening us, and I get the care managers on my head, get the patient out. The patient has an extended stay. Well, sometimes what I need to do in the hospital needs an extended stay, and I can't get them out, and I can't get it done in 4.5 days. So I believe hospitalization should be an outcome. I believe heart failure hospitalization should be an outcome. And hospitalization equivalents, because I, as many of my colleagues who are sitting here, avoid the hospitalization. If I have to give IV Lasix in the office, I will. And I try to keep them out of the emergency room and out of the hospital. So those are important events in places such as ours who have high volume and high levels of experience. We've known this for a long time. This isn't new. Everybody thinks this is something new and shattering. We've known that being in the hospital is bad for the patients and that they have a high mortality within a year, within 6 months. It doesn't take long to see it. So outcomes don't have to be 2 years for hospitalization. You're going to know what you need to know within 90 days because that's where the highest rates are. And you may say, well, come on, this is heart failure. They're supposed to be sick. They're supposed to die. Well, when we put them into trials, they actually do pretty darn well in trials with a very controlled setting. I also know that the more they get hospitalized, the higher the mortality. We don't need to do these experiments. We know this. This has been well known. But I want to give you reality. This is a list of medicines that an average patient leaves the hospital with. I counted them. It's 13 drugs. By the time we see them in our short-term clinic, which is very successful, not run by me, it's run by pharmacists, we get down readmission rates down to 8%, and we get rid of what I call the junk. The junk medicine includes the laxative, the stool softener, the sleeping pill, the pain pill, the pantoprazole, everything they got in the hospital. It's really unnecessary. How confusing. How many of you can take 13 drugs in a day? I don't think the patients can, but this is a real list of what the medications are taken from our patients. And by the time they leave us in that post-discharge clinic, especially because they're diabetic, they may have coronary disease, I have the statins, they're down to about 8 drugs. So what gives me confidence that I can get them on guideline-directed medical therapy? It's not totally impossible. And that reverse remodeling should mean that the outcome is going to get better. Every time we've done anything that causes reverse remodeling, like beta blockers, the patients actually have a better outcome. That exercise therapy is safe. We've done this. We've done the trial, and it should be added. That capturing health status can be done, and that I do it clinically, and I'm going to show you the data. And so I put the post office box here because I tell the patients, you're like little cubby holes, and I put all this information into little cubby holes that will give me the total picture of you, and you, where you are now, and where you're going. They don't want to see the Kaplan-Meier curves. They want to hear what I have to say about how they're going to do. So why do I insist on guideline-directed medical therapy? And I thank Dr. Yancey for putting that acronym into the guidelines because I use it all the time. It works. It actually works. You have to be consistent. You have to be patient. You have to know the drugs you're using. You have to be confident. You have to have self-efficacy that you know how to do this. And we do follow biomarkers. The inability to medicate, and this is Lynn Stevenson data right here on the panel, is a bad outcome. If I can't get the patients medicated, that is a very bad prognostic sign. But by people who do this all the time, not the checkbox. Good, I did it. I gave an ACE inhibitor. Check. Can it be done? Yes, it can. Greg Fonarow data from the IMPROVE heart failure trial, this is real-world data, where the addition of the medicines, every time you add one, you improve outcomes. So we've got plenty of proof. We don't need any more proof in here. Reverse remodeling, you can use anything you want, LVEDV, LEDV. I'm liking LVESVI because I'm seeing a lot of consistency in the literature. Ejection fraction alone may not cut the mustard. I need to see that the ventricle is changing. So reverse remodeling should be linked to a favorable outcome, and there should be some causal relationship. Should that be an outcome? Yes, I think so. This is stats from when I was at CASE, our heart failure clinic, showing you that when patients are under a team approach to care, guess what? We have very few admissions when they're coming to clinic. And this is a large number of visits by year, and yet very few hospitalizations. And take a look at these. These patients were sick. New York Heart Class 2.4. We have a lot of women absent in many of our trials, and some of you know that's one of my pet peeves. And beta blockers, well done, well up-titrated, can actually reverse remodel. Not everybody, but there are patients that can do it, and you need to give them the chance to do it. So this was from our own clinic. We had a group of patients that had a significantly improved ejection fraction with peak VO2s of 13.8, which is low, and an initial class of 2.4. Changes in ejection fraction were remarkable, as they were changes in ventricular dimensions. And guess what? When we did this statistically, the most prominent finding was the dose of the beta blocker, 139 in patients who improved. This is a metoprolol equivalent, and 98 in those that did not. What about health outcomes? I already heard Daniel present that you want to hear more about health outcomes. This is from our HF Action trial that I know Chris O'Connor is going to be talking more about. We used the KCCQ to show about exercise. What did exercise do to these patient-reported outcomes? And even though we had a statistically significant benefit, within 3 months that persisted for 2 years, more and more patients shifted to a higher number. So we had the proof that exercise actually does improve health outcomes. And this is, again, in the clinic. I've been using these for years when the patients come to clinic, is I want to know what their health status is when they walk in the door. But you got to do it the right way. There is a process to give this, even in an unblinded trial. It's not the people who are taking care of the patient who gives them the questionnaire. It's somebody in the front office. I don't want to be involved when they're filling it out, because I don't want them to feel that patients actually do try to protect us. They don't want you to think that they don't like what you're doing or that they feel bad. So we give it by somebody who's totally outside of their daily care. And I'm not even in the room. I don't even want to be in the room. And so when we take this questionnaire, we do it as unbiased as possible. So here's a population with an EF of 19.8%. This is real. This is our clinic at Case. And here are the results. And for those of you who don't know the KCCQ well, the higher number, the better the health status. Not quality of life, health status. And you can see that the New York Heart class just really goes right down the line with the value of the physical limitation and the total symptom score. So that if I break it down, you have a pretty good sense, besides that New York Heart class, which is so imprecise and so subjective, but yet pretty darn good to look at outcomes, that it tracks exactly as the questionnaire does. And this is now today, this is now 10 years later in my clinic at Montefiore, where the KCCQ overall score is 52. That's pretty bad. And those are patients leaving the hospital with a pretty bad health status, even though there's a wide variability and a high standard deviation. HFpEF, very quickly, the bane of my existence. I have no idea what to do with these patients. I try to get their blood pressure down. I try to get their diabetes controlled. I try to put them into exercise program. I don't want them to have atrial fibrillation, and so I'm going to leave you with a new outcome, atrial fibrillation. A very bothersome, very common comorbidity that we're seeing in this population. The treatment guidelines are kind of very specific. They tell us to treat blood pressure, and the new ones will be hitting the door. Clyde may be able to talk a little bit more about that. But what do I have a problem with is that all the trials are different. The entry criteria has been different, the ejection fraction has been different, the way the ventricle looks is different. How are we ever going to get to this when we don't even have a very good, solid definition of HFpEF? And atrial fibrillation is very often the presentation, and I find my colleagues running to take care of that atrial fibrillation. Let's control the ventricular rate, but what's underneath, which is the heart failure, very often gets ignored. So perhaps new onset, incidence of atrial fibrillation could also be a health outcome. And yes, I use spironolactone because right now, that's the best data that I have from the NIH-sponsored TopCat trial. Exercise, highly ignored, and yet we do have data. There's smaller trials, they're not the big, large randomized trial, but we do have data that the HFpEF patients do well with exercise. And I've got some of them walking in the home, walking around their dining room table, because in the Bronx, this time of the year, you can't always go out and walk. A little cold now, ice and snow on the streets. So I have them walking around the dining room table and telling me how many times they can go around. It's still exercise. It's just not on a treadmill. And then my key points for outcomes in HFpEF: reduction in all-cause hospitalization, improvement in objective function, their ability to actually rehab, well-captured symptoms, which is very hard to do in the absence of AFib. And then finally, devices for HFrEF. What do I want in a device? I want it to have biologic plausibility. I want it to improve physiologic parameters. And notice, I'm not that interested in long-term mortality, but I am interested in hospitalizations and my ability to up-titrate drugs and to continue therapy even with a device on board. So let me finish up here because I don't have a lot of time. ADHF, acute heart failure, again, a comma in the process of care where we deal with the iceberg and there's so much more going on underneath. Why do we think that 48 hours of a treatment is going to reverse this? We have failed at many of our acute heart failure trials because I don't think we're looking at it appropriately. Again, it's a comma in the whole disease process, and when we ignore the disease process, we're ignoring everything that has gone on underneath until the patient now comes in with orthopnea and fatigue. So with those thoughts, I leave you there. Thank you, Daniel.
Thanks so much, Ilyana. That was a great perspective from a clinician. Next, we'll hear from Dr. Philip Adamson, Vice President of Medical Affairs and Medical Director at Abbott, which was formerly St. Jude Medical. He's representing AdvaMed. And I'll just add that we'll have a few minutes at the end of all of the presentations for any Q&A from the panel. Thank you.
Thank you, Professor Redberg. Members of the Coverage Committee, particularly Dr. Canos and Dr. Chan, for this invitation. I'm honored to speak in front of such distinguished folks on a committee and a panel. Ladies and gentlemen, I'm here to express the opinion of industry on behalf of a common group called AdvaMed that represents all of industry that is responsible for the development of novel interventions and technologies for patients with heart failure. I'm Phil Adamson. I'm a heart failure cardiologist, and as Dr. Redberg mentioned, I'm medical director at now Abbott and involved in many clinical trials to evaluate novel technologies to improve outcomes in our patients with heart failure. And really, my task here is to describe industry's scientific rationale for identifying appropriate endpoints for clinical trials, and clinical trials testing novel interventions to benefit Medicare patients. We're focusing on which meaningful patient-centric outcomes are appropriate to evaluate new interventions, because we are actually seeing some improvement in longitudinal care and disease management of patients with heart failure. We have this is giving us new goals. It's giving us new therapies and new ways to allow patients to remain stable in their own homes and avoid hospitalizations. Today is very important. The assessment of endpoints and outcomes will help us to maintain the progress that we've been seeing in management of these patients and to ensure that success will continue as we manage these very, very symptomatic and difficult patients to manage. And frankly, we all know that heart failure is an exploding pandemic with expectations of the prevalence to double within the next 15 years. So we really, I think, have to have a concerted effort to guide how we develop novel tools to manage patients with heart failure and deal with the problems that are associated with this chronic disease. You know, I've spent the last nearly half my life as a cardiologist taking care of heart failure patients, and those patients have taught me a lot about how this disease affects them and what they want. And I've had innumerable lessons taught me from my patients. And I've also learned in the last 2 years a lot about industry. As a member of industry, I've learned that one of the most important things is that industry finds really no value in innovation that's made just for the sake of innovation. In fact, our goals align with CMS and other organizations such as the American Heart Association. Our purpose is to provide solutions for unmet clinical needs, providing the highest levels of patient-focused scientific evidence to improve the quality of health care for Medicare beneficiaries. And in fact, we agree with CMS, and we agree with the American Heart Association, that heart failure hospitalizations are very important. And this is a very important clinical endpoint to manipulate and to change as technologies improve. Frankly, heart failure hospitalizations are horrifying to patients. They're potentially deadly. And these patients who otherwise have reasonably stable heart failure syndromes are faced with the possibility of death, drowning in their own juices. And this stress and trauma doesn't just affect the patients. It affects their families, their caregivers, and their long-term outcomes, their psychology, their socioeconomic status. Heart failure hospitalizations are devastating and worthy of our attention. As Dr. Pena mentioned in some of her slides that were published, patients, when asked if they could stay out of the hospital and avoid symptoms, would that be better than staying alive longer? Most answer yes. Please make my symptoms better and keep me out of the hospital. Don't just prolong my life. Therefore, I think there's clear alignment between CMS and AHA and the most important group, our patients, that preventing hospitalizations is a worthy endpoint to validate novel clinical technology. I wanted to spend a little bit of time going through the process because successful innovation processes must first focus on the end result. The end result is the ultimate use of clinically meaningful and appropriately validated tools. Industry is called upon to produce the highest level of scientific evidence to satisfy rigorous regulatory, reimbursement, and coverage approvals. The process involves discovery and clinical development, which for most technologies culminates in a pivotal trial that evaluates the novel innovation. And it's important to note that in these clinical trials, many times the control group itself receives better care than in the community. That's why discussing endpoints is so important, and why the common goal of assessing safety and effectiveness is a rigorous process. However, it is important to note that industry continues to gather data after FDA approval and after CMS coverage, and uses that information from this period to ensure that ongoing safety and effectiveness in generalized use of the new intervention is present, and to use this information for revision, rediscovery, redesign, which are mandatory for any product that's designed for the benefit of a heart failure population, because many breakthroughs are concomitant and simultaneously occur over time. So where you end up may be different than where you start. So this ever-changing landscape of healthcare delivery for patients with heart failure is very important to assess and reassess. So with this in mind, the proper selection and agreement on appropriate endpoints for validation of novel clinical tools is critically important for the sustainability of this traditionally successful cycle of development. You know, heart failure is really a syndrome that can be described as a journey and is associated with several different phenotypes, which we all know, several different etiologies and comorbidities. And unfortunately, there really isn't a one-size-fits-all endpoint that applies to all aspects of this heterogeneous journey. This figure actually outlines a very simplistic view of heart failure progression, but may be useful to identify where unmet clinical needs exist, and illustrates how endpoints are dependent upon where the patient is in the journey. So let's start at the beginning. With a hemodynamically stable, ambulatory heart failure patient with reasonable functional capacity, reasonable quality of life, and mild to moderate persistent symptoms. And actually, this represents the vast majority of patients with a diagnosis. And you know, we've learned a lot. We've learned a lot over the years about this phase of heart failure, and at least for patients with reduced ejection fraction, guideline level evidence supports drug and device interactions or interventions to prevent disease progression. Unfortunately, no clear guidelines exist, as Ileana just mentioned, for patients in this phase 1 portion of this journey who have preserved ejection fraction heart failure, despite several clinical trials evaluating promising interventions. Many patients eventually experience worsening symptoms and transition to seek urgent care, and many times are hospitalized to receive IV rescue therapies. And, we've learned a lot about this transition period from hemodynamically stable ambulatory patients who transition into the decompensated state, requiring hospitalization. In fact, it's a process that takes much longer than what we originally thought. It's characterized first by early increases in filling pressures that can be detected weeks before patients develop symptoms, leading to a pre-symptomatic congestion, hemodynamic congestion phase, which is associated with changes in cardiac autonomic control, and eventually interstitial edema, shortness of breath at rest, pulmonary edema, and the need for hospitalization. And in fact, over 90% of patients who are hospitalized for heart failure exhibit severe symptoms of congestion in the presence of excellent perfusion of their body. So it's the congestion that tends to drive hospitalizations. Unfortunately, consistent prospective randomized clinical trial outcomes testing a variety of methods to monitor patients using daily weights and early detection of symptoms with the hopes of preventing hospitalizations in this transition period have failed. And it's probably due to the fact that the transition from stable ambulatory to decompensated is characterized by this significant pre-symptomatic stage in which we can't see with signs and symptoms that the patient is worsening, and the patient doesn't know because they don't have symptoms developing. Weights change, symptoms develop, but they may be too late to provide effective guidance to prevent hospitalization. A clearer understanding of this transition from stable to decompensated discovered an unmet clinical need. New interventions tested in this transition phase should be expected to identify patients when they develop hemodynamic compromise without the development of symptoms, and should have the goal of preventing subsequent hospitalization. So when we test things in the transition stage, knowing what we know now about that process, heart failure hospitalization prevention is a very important outcome of those evaluations. Now, once hospitalized, patients transition to phase 2 in this diagram, in which typically high-dose IV diuretics are delivered as rescue therapies. And again, multiple clinical trials evaluating several promising interventions at phase 2, once patients are acutely decompensated and in the hospital, have consistently yielded negative results. And Ileana touched on that in her talk. Even recent trials testing novel natriuretic proteins have failed to impact clinical outcomes. So it seems that stage 2 actually may be too late in the course of this progression to congestion, and little can be done to alter the course of progression. As patients transition then into the number 3 there, we've unfortunately learned that after about an average of 5 days in the hospital for rescue therapies, over half the patients are discharged with continued congestion. The same thing that brought them into the hospital. This phase 3 transition from discharge to home is an incredibly important time because 25% of patients who are discharged are actually readmitted within the next 30 days. In fact, if you look longer term, 50% of patients are readmitted in 6 months, and over 70% of patients are readmitted after a year. Clearly, stage 3 of this journey represents an unmet clinical need to more appropriately discharge patients and provide more effective follow-up. New technologies introduced at this time point should demonstrate a reduction in readmission rates as a meaningful outcome. Frankly, this readmission cycle is difficult to stop. And each time the patient cycles through this process, their disease worsens and progresses. Many patients who repeatedly decompensate eventually transition into a totally different pathophysiology we now call advanced heart failure or refractory class 4 stage D heart failure, shown as number 4 in the diagram. Heart failure pathophysiology now changes to include poor systemic perfusion, which is a very serious problem requiring very serious interventions. Therapies and outcome testing for this phase are completely different and include providing implantable mechanical circulatory support systems or transplantation for appropriate patients. Importantly, for patients unable to receive advanced therapies, identification of them as an advanced patient should provide an opportunity for palliative care, as near-term death is really hard to avoid. So the ultimate goal then for management of a patient with chronic heart failure is to manage and maintain stability and avoid decompensation. Novel interventions being tested for this purpose should prevent the ill effects of decompensation, which include progression of adverse myocardial and vascular remodeling, leading to chronically elevated cardiac filling pressures and poor systemic perfusion with progression of their disease. Clearly, as Ileana has mentioned and shown this data from Professor Stevenson's lab and led by Dr. Setaguchi, patients who have multiple hospitalizations are at higher risk for mortality. In fact, patients experiencing just 2 admissions are nearly twice as likely to die compared to patients admitted only once. More recently, though, very interestingly, it became clear that no matter how decompensation was treated, whether it's in a traditional hospitalization or emergency department visits or even outpatient intensifications of therapy, decompensation leads to higher long-term mortality. This data from the Paradigm HF trial demonstrates a 3-fold greater mortality in patients experiencing any decompensation event, regardless of the venue for rescue therapy. Now let me orient you to this slide. The solid black diamonds represent death rates in patients without a clinical decompensation event, and that's compared to the red diamonds, which are patients who had intensification of therapy. The green diamonds, ER visits with IV care, and the blue diamonds are traditional hospitalizations. And look at the mortality associated with these events. The mortality differences between no events is dramatic, but the mortality difference between experiencing decompensation are very similar, regardless of the venue in which rescue therapies are delivered. In fact, when in this trial, which ended somewhere in the 2014 range, it became clear that clinical practice is evolving to rely on more extended outpatient hospital visits to provide IV therapies, which is represented in the second bar of each of these pairs. So you can see over time that clinical practice patterns have evolved to rely on less hospitalizations and more outpatient-based rescue therapy treatments of decompensation. The decision then about what endpoints are appropriate is dependent upon where the patient is in their journey and when the innovative treatment is introduced. Clearly, heart failure hospitalizations and decompensation events are associated with very poor long-term outcomes. But let's focus more closely on the components of the journey. It's certainly desirable and a patient-preferred outcome to maintain stability and avoid decompensation altogether. As mentioned, multiple interventions tested in clinical trials while patients are acutely decompensated and already hospitalized have produced really consistently disappointing results. The benefits of maintaining stability are now clear, and it should be apparent that heart failure hospitalizations are important targets as primary endpoints in heart failure clinical trials. And as clinical practice evolves, another important measurement of success may be to prevent ER visits requiring IV therapies or urgent but short in-hospital stays that do not qualify as traditional hospitalizations as we've defined them in the past. As is always the case, clarity of endpoints that depend upon exercising clinical judgment can only be achieved with careful evaluation of each event. This requires thorough, unbiased, blinded, expert adjudication of the events as part of the routine clinical trial design. An event assessment should include confirmation of the patient's clinical status at the time of the event, documentation of all therapeutic interventions provided. Additional careful medical record review should identify investigator involvement in the decision to administer IV diuretics or provide hospitalization, especially in single-blinded trials. I think it's important to capture all-cause hospitalizations and include either them as secondary endpoints or used as observational data to ensure that a change in heart failure hospitalization is not really just a shift in resource utilization or diagnostic coding. Finally, combining decompensation events with mortality as a composite endpoint is reasonable. However, if mortality is not included in a composite primary endpoint, mortality rates must be monitored to ensure complete assessment of competing risks. So let's consider now patients who develop a need for an advanced therapy, shown as phase 4 in this diagram. And it's important that endpoints chosen in clinical trials should be disease-specific. Patients with refractory advanced heart failure many times are acutely unstable and require prompt intervention to survive. And I think we all remember the startling difference in mortality seen in the rematch trial between medically treated advanced heart failure patients and those receiving mechanical circulatory support. It'd be really difficult to envision another trial examining medical management in this group. However, once the advanced therapy is delivered, then it's also important to recognize that the disease state in patients who receive advanced therapy is different, vastly different than ambulatory heart failure. For example, post-transplant immunosuppression and rejection represent many poor outcomes in transplant groups. Patients living with mechanical circulatory support also have a unique pathophysiology, which includes coagulopathies, embolic events, device-related infections, and device malfunction. However, these patients start their journey into mechanical circulatory support with totally different and severe baseline condition, which is associated with very high mortality using medical therapy alone. In this regard, new iterations of mechanical circulatory support should focus primarily on restoring functional capacity, improving quality of life, and decreasing complications associated with the pathophysiology that's acquired with the chronic device implantation. In fact, hospitalizations for acutely decompensated heart failure are rare after VAD implantation and may not be a meaningful short-term endpoint. Hospitalizations for bleeding, infection, device malfunction, however, would be key elements of measuring success in these patients. Particularly important for this context is that currently available quality of life measurements are designed for patients with chronic heart failure and may not be specific to this new pathophysiology that exists post-VAD support. While established quality of life measurements document improvement from baseline in patients receiving MCS, the remarkable post-VAD clinical improvement is compared to a very severe baseline. In this regard, new disease-specific quality of life markers are likely needed to evaluate the durability and the magnitude of specific components of quality of life that capture the unique challenges facing patients while they live with mechanical circulatory support. In this regard, then, disease-specific quality of life measurements are now recognized as one of the 3 pillars of quality healthcare delivery, along with clinical effectiveness and safety. The most clinically validated instruments, as Ileana has mentioned, are the Kansas City Cardiomyopathy Questionnaire and the Minnesota Living with Heart Failure Questionnaire. Although these instruments are not perfect, favorable changes in each of them independently predict a favorable outcome and are robust enough in patients with chronic ambulatory heart failure, at least, to represent a meaningful clinical outcome. Longer-term assessment, however, of quality of life using these instruments becomes confounded with the comorbidities that commonly accompany the heart failure syndrome. Furthermore, questionnaires assume that the patient has sufficient cognitive functioning to understand and provide accurate answers, and the prevalence of cognitive dysfunction in patients with heart failure may be underappreciated. Assessment of quality of life beyond 1 year from an innovative intervention is probably problematic. But developing novel quality of life instruments that focus on patient-specific defined worst symptom or psychosocial stressors, along with locus of control issues, are risky in the context of evaluating a new technology. A negative result with a new quality of life marker may actually be due to the novel quality of life marker itself, rather than the new technology. So I think we need creative ways of evaluating new quality of life measurements that are meaningful and obligatory endpoints in clinical trials that match the disease that's present. So how about functional assessment? Change in functional capacity are also important markers for a successful novel intervention. All functional assessments, however, assume and are limited to patients who can participate in the measurement without confounding impairment from comorbid conditions such as arthropathies, amputation, or paralysis. Certainly the easiest and most widely used marker is a simple 6-minute hall walk test, which remains a good measure and a good measure of functional capacity with appropriate diagnostic and a prognostic value. More sophisticated cardiopulmonary metabolic stress testing with the goal particularly of measuring VO2 max provides an excellent measure of exercise capacity, but we believe should be performed under specific conditions such as core lab oversight for interpretation of borderline tests using a priori objective methods intended to validate tests that would otherwise be considered inadequate. Additionally, statistical analysis plans should be in place to account for patients who subsequently are unable to repeat the test for reasons unrelated to the fundamental question being tested. Functional improvement in a patient-centric is a patient-centric and preferred outcome of any intervention tested in the heart failure journey. So how about surrogate markers or intermediate markers? They certainly are attractive for use in clinical trials since shorter-term changes may reflect that the intervention is successful and may give rise to conclusions about long-term benefit. For example, it's reasonable to consider a reduction in valvular regurgitation or stenosis as an appropriate endpoint for novel valvular interventions. Reversal of adverse ventricular remodeling, as Eliana mentioned, is a very gratifying thing to see and usually measured as improvement in left ventricular systolic or diastolic indices and directly correlate with improved survival. Reversal of adverse remodeling is known to occur with successful drug and device interventions and should be considered a measure of success. In patients with acute cardiogenic shock from acute myocardial infarction or myocarditis, temporary mechanical circulatory support may prolong survival long enough for improvement in ejection fraction to occur. And that may be a situation in which left ventricular ejection fraction may be an appropriate intervention. And finally, favorable changes in biomarkers such as NT-proBNP or B-type natriuretic protein or ST2 may provide sufficient evidence to support further investigation of novel interventions. And particularly applicable to patients with reduced ejection fraction heart failure, congruent improvement in biomarkers, functional capacity, and quality of life as a composite is now a means for expedited regulatory review and potential early FDA approval, with the expectation of further real-world evidence development in the post-approval period. In that regard, then, fairly recent development of credible real-world databases in very large populations also provide meaningful opportunities for continued evidence development. Data objectively extracted from these databases have the potential to corroborate the results of randomized clinical trial data and have the potential to produce a so-called cultivated cohort, which may provide appropriate concomitant comparator groups. Multiple databases are now available from several sources and may provide novel means to more fully evaluate generalizability and, importantly, clinical effectiveness of a novel intervention after it's made available for clinical use. In summary, then, disease-specific non-mortality outcomes are scientifically sound methods to evaluate novel interventions for patients with heart failure. Preventing decompensation events, regardless of the venue in which therapy is delivered, should be considered as appropriate in clinical trials, in heart failure clinical trials. The goals of allowing patients to remain stable and at home is patient-centric and appropriate. Stability many times improves quality of life, and especially in those patients whose baseline condition is characterized as quite severe. Functional improvement is an important outcome, very important assessment of innovation, and can be considered as primary endpoints under certain conditions and circumstances. And certainly combining congruent improvement in biomarkers, quality of life measures, and functional capacity is a very strong signal for overall clinical benefit. We applaud the efforts of CMS in stimulating this discussion about how to measure success with novel interventions that are designed to improve the patient experience with heart failure. Alignment of non-mortality endpoints as a criteria for regulatory and coverage decisions is critical to ensure sustainability of clinically meaningful progress and innovation, with the hope of providing meaningful solutions for vexing unmet clinical needs. Thank you very much.
Thank you, Dr. Carroll. I'm sorry, thank you, Dr. Adamson. I'm very sorry. Looking ahead, I'd like to introduce Dr. John Carroll, Professor of Medicine at the University of Colorado School of Medicine and Director of Interventional Cardiology. Dr. Carroll.
Thank you, Dr. Redberg. It's a pleasure to be here this morning and to share with you some thoughts on what healthcare outcomes should be of interest to CMS in studies for heart failure treatment technologies. I have no financial disclosures relevant to this topic. My institution and I are investigators in a variety of clinical trials in this space. So the goal is to advise CMS about the ideal healthcare outcomes and research studies of heart failure treatment technologies and appropriate follow-up duration. I will try to stick to the topic. My perspective is perhaps different from others here. I'm an interventional cardiologist, and my areas of expertise relevant to this are heart failure related to valvular heart disease and other transcatheter approaches to valve replacement and repair, and CHF related to intracardiac shunts treated with a variety of different transcatheter technologies. That's my perspective. Clinically significant valvular heart disease is really becoming prevalent in our aging U.S. population, as shown here. Moderate to severe mitral valve disease, aortic valve disease dramatically increases with age. And notice that the final age is greater than 75, and certainly now we have many of us living beyond that point. So there are major issues that we have to discuss and make explicit that are confounding an outcome assessment, and one of them is the issue of advanced age, and the other is socioeconomic status. And certainly in this area of heart failure in general, and also in the areas I work, the focus is on the elderly. It is a fast-growing segment of population. Cardiovascular disease is a leading cause of morbidity and mortality in these people, and they have the presence of significant comorbidities and different forms of cognitive dysfunction, social support, diminished functional status. All these things influence our decision-making and treatment outcomes. Furthermore, we have to deal with certain realities that life does have a finite expectancy, and as we age, that the expected life expectancy drops, and that's relevant if we're talking about therapies that are applied to 80-year-olds versus 50-year-olds. And these survival benefits that some of these treatments do have and have been shown in randomized clinical trials are important, but the other benefits are extremely important for judging the value of transcatheter therapies, such as functional status, quality of life, and freedom from hospitalization. And these outcome assessments must be put in a broader context of the patient's daily existence. And there are a variety of social determinants of risk and outcomes for cardiovascular disease that we all confront on a daily basis, and include some of these items demarcated on the left. And these markers of socioeconomic position often are not captured when we do clinical trials, when we assess long-term outcomes, and are key issues that are underappreciated but have a huge impact on outcomes. So in preparing for this, I tried to be very explicit about the different domains of outcomes that need to be considered: survival, but also objective assessment of the disease-specific anatomical physiologic variable that the treatment addresses, the presence or absence of treatment complications, the improvement or lack of in patient-reported health status, the objective functional assessments, and the freedom from hospitalization and loss of independent living. So in terms of the objective assessment of the disease-specific anatomical physiologic variables that treatment addresses, we have to have a time frame, and typically the time frame for assessment is immediate to 30 days. 1 year is important if durability is a potential issue with the treatment. And I always hesitate sending movies as part of talks, but on the left is a patient with an aortic bioprosthesis that is degenerated and there's severe regurgitation, and the right is after the implantation of a transcatheter valve within that, and the two videos show severe aortic regurgitation on the left and the absence of aortic regurgitation. So that's the assessment of the treatment effect. We can further assess the outcomes directly related to the disease process by other measures, non-invasively or invasively, and this shows the pre and post impact on intracardiac and aortic pressures of the restoration of a competent aortic valve. Outcome assessment by cardiac ultrasound is central in the heart failure and the transcatheter and surgical valve area. The pre-procedure documentation of severe mitral regurgitation must be paired with a post-procedure documentation of the degree of reduction using standardized methodologies that we have arrived upon. Next, we must assess the presence or absence of treatment complications, and the time frame of that is really throughout the patient's life, but starts with the immediate to 30 days. But 1 year is important because there are some late complications that are unique to different treatment modalities. So we've learned a lot about assessment of physician and hospital performance that's relevant to looking at outcomes as CMS wishes to do. For example, an isolated surgical aortic valve replacement with a composite score based solely on outcomes. We have to risk standardize mortality, but we also have to look at the all or no risk stratification morbidity occurrence that is very important for patients and for us as clinicians. And those include sternal infection, reoperation, stroke, renal failure, and prolonged ventilation. And this derives from the work in the SDS group. Next, we have to get an idea of whether patients' health status has improved from their own perspective or has not improved or potentially has deteriorated. And there the time frame is obviously prolonged. It starts with the establishment of baseline measurements that serve as an index for the individual patient to see to what degree they improve or not. And it's particularly important in the elderly or those with comorbid conditions that could impact on their ability to benefit from a treatment. So the importance of measuring patient health care status is outlined here by my colleagues, some of whom are at Colorado, like Dr. Rumsfeld. So we are talking about living longer, living better. We are talking about patients' reported health status, which includes not just quality of life, but the symptom burden, the functional status, both social and other. Validated patient health care surveys are important that need to be disease specific, but sometimes can be broadened to patients with multiple forms of cardiovascular disease and allow for a quantification of this critical patient-centered outcome. And these patient health care status surveys have been used to successfully document the impact of treatments, and certainly we use them in long-term follow-up in clinical registries like the TVT registry I'm involved with. And as also a baseline is a marker for adverse outcome and healthcare costs. So here, if we look at this spectrum of patient-reported health status, we start with the disease and treatment and assessing the symptoms, the functional status, and the health-related quality of life. And we see, as shown below, all the different things that impact on how a patient may respond to a questionnaire and come up with different answers, different variables. So specifically within the TVT registry, when we were developing the basic data elements that needed to be gathered, we decided in the KCCQ as a health status measure that integrates multiple different aspects of symptoms, functional status, and quality of life into a single measure, and has been documented to be reliable, patient-centered, and easily collected in routine clinical practice after adequate education. And this shows some of the impact that we've been able to assess using the large number of patients entered in the TVT registry, which is approaching 100,000 patients who've undergone FDA-approved, commercially available transcatheter therapies for valvular heart disease. And what do we see here? We see there are patients who fortunately have large improvements in the KCCQ. We see those who have moderate improvement, greater than 10 being what seems to be an objective, realistic goal. But then there are patients who have no improvement, no change, or decreased at 30 days. What does that mean, and what can we do about it? Here we see transcatheter aortic valve replacement according to baseline health status. So it has prognostic value. It's not just looking at deltas, but it helps us assess what might come down the road. What are the chances of patients benefiting from these therapies? Something very, very important as we go forward of trying to predict in whom is a treatment going to be beneficial. And that helps inform patients to make their decisions about whether or not to undergo treatment. And the ability to develop conceptual frameworks of describing success and not necessarily failure, but lack of success when it comes to various treatments is shown here. A publication from Dr. Arnold looking at the interplay of both KCC score, but also patient survival, and trying to identify in whom is there not, and these are individual patient marks, in whom is there a poor outcome, and can we predict it? And the reasonable definition of a poor outcome, what is that? Certainly death, certainly persistent low KCCQ as a reflection of patient's health status, and further decrease in that score, of course, is not something we'd like to see when we're trying to help people. Increasingly, we're entering an era where we want to be able to predict outcomes and then assess what happens in terms of assessing the validity of predictive tools. And that's where so much effort is going into risk model algorithms to predict mortality, immediate treatment related, but also long term. And if we can do a better job of predicting who responds and who does not respond to a treatment, wouldn't that be fantastic? To not only bring that therapy to the people who respond, but not subject other people to treatment that they may not respond to and the associated huge healthcare costs. So we need objective functional assessments. The new metrics of success are in front of us and shown here with this individual undergoing a functional assessment of not only how they report the success or failure of how they're doing, and using more than the simple classification of New York Heart Functional Class, but looking at 6-minute walk tests, which can be done in the majority of these patients, but some patients cannot due to orthopedic and other issues that prevent them from walking. When we look at new therapies like mitral valve clipping procedures and looking at changes in New York Heart classification, baseline versus 30-day, we see significant improvements in their functional class, affecting the majority of patients, but not all. Certainly, great emphasis has already been placed on the freedom of hospitalization, but also the loss of independent living is as important as many other parameters for our patients. The time frame of assessment is important. It can be done early on, but we really have to, again, look in many of these therapies beyond acute procedural results, but look at outcomes 1 year that are a reflection of many things, not only the procedure, but the quality of care subsequently. And after transcatheter aortic valve replacement in the TVT registry, we're able to see what happens to these patients when they're discharged. Do they actually go home? Do they die? Are they transferred to a rehab institute, or do they go to a nursing home? We need to look at these parameters of what happens to patients after therapies. This is an important metric. Certainly, one of the benefits of the stakeholder engagement and the participation of CMS and FDA in professional registries like the TVT registry that's jointly sponsored by STS and ACC is the ability to link patient records with long-term CMS data and look at rehospitalization rates as shown here. This helps us further refine the benefit of therapy and patient selection criteria and identify some unmet needs and how we might improve things. So in conclusion, the assessment of outcomes must address these 6 major domains that I've identified here. Survival is one. The second is objective assessment of a disease-specific anatomical physiologic variable that the treatment addresses. And third, the presence or absence of treatment complications. Fourth, the improved patient-reported health status. Fifth, objective functional assessment. And sixth, freedom from hospitalization and loss of independent living. The timing of the assessment of the different domains of outcomes should include baseline assessment for comparison to post-treatment, immediate to 30-day survival, but also objective assessment of these disease-specific variables that the treatment purportedly addresses, and the presence or absence of treatment complications. And at 1 year, survival, improved health status, objective functional assessment, and freedom from hospitalization and loss of independent living are key. Thank you.
Thanks very much, Dr. Carroll. Next, we'll hear from Dr. William Lawrence, who is Associate Director of Clinical Effectiveness and Decision Science at the Patient-Centered Outcomes Research Institute, and Dr. Larry Allen, who is Associate Professor of Medicine and Medical Director of the Advanced Heart Failure at University of Colorado, Denver, a colleague of Dr. Carroll's.
Good morning, and on behalf of both Dr. Allen and myself, thank you for having us this morning. So first, just disclosures for myself. I'm an employee of PCORI and have no other conflicts. So this is a co-presented presentation, and just a brief overview. I'm actually going to give just a very brief introduction towards patient-centered outcomes, and then Dr. Larry Allen will talk about his work working with patients on a LVAD decision aid. So first, just a couple words on the Patient-Centered Outcomes Research Institute. I've got here our mission and goals. Really the big thing I wanted to point out is that our mission is to help people make informed healthcare decisions by promoting and producing high integrity evidence-based information that comes from research guided by patients, caregivers, and the broader healthcare community. So my main point today is to make sure that our stakeholders are involved in the research from the start. So we fund patient-centered outcomes research, and this is a form of comparative effectiveness research that what we're really interested in today is that it considers the patient's needs and preferences and the outcomes that are most important to them. We're also interested in what works not only for the whole population, but what works for whom and under what circumstances. And then finally, interested in helping patients and other healthcare stakeholders make better informed decisions about health and healthcare options. So just a couple of things. We're interested in the concept of patient-centeredness. So we're actually interested in basically answering the questions or examining the outcomes that matter to patients within the context of their own preferences. That our proposition is that research questions and outcomes should reflect what is important to patients and the caregivers. And the other thing is that we're interested in patient and stakeholder engagement. So stakeholders should be involved from the start of the research and not just basically the subjects of the research. So with that introduction, I'll turn it over to Dr. Larry Allen from the University of Colorado to talk about his work with LVAD patients.
So thanks, Bill, and thanks to PCORI for inviting me, and thanks to CMS for giving me the opportunity to hopefully contextualize this discussion about outcomes from the patient perspective. And today I'd like to use some work we've done with left ventricular assist devices, but I think it applies to a variety of cardiac devices. These are my disclosures. I do some consulting for Novartis, Janssen, and ZS Pharma. Have been funded by the AHA and PCORI. So I think this is a good way to think about how outcomes inform what we do. So here you have a doctor who's saying, when a patient asks, doctor, I want to choose how I'm treated, the doctor says, you're not just ill, you're deluded. But I actually think this sets up the framework for how outcomes really help us deliver good health care. The first thing is that outcomes help us decide what are medically reasonable options for this patient. I don't know whether I can recommend one or two or three options to a patient or say that that's not an option unless I have good quality data that tells me whether that's good for the patient or bad for the patient and what the balance of that is. But rarely do I come to a conclusion where I know exactly one thing is right for this one patient. So we also need outcomes presented to patients in ways that they can understand which option among the ones that may be medically reasonable is actually right for that individual patient. So as we consider the outcomes we're measuring, we need to think about not only what's good kind of from a standard or societal perspective, but how do we help individual different people sort through those options in a way that they can then decide. I think outcomes also help us decide or approach the way that we present medical options to patients. So sometimes we use behavioral counseling when scientific evidence for benefit strongly outweighs harm. So in smoking cessation or a beta blocker for heart failure with reduced ejection fraction. And then decision support designed to describe, justify, recommend, and engage is most appropriate. At the end of the day, even when we think that smoking cessation is the right thing to do, and that's the one option in front of this patient, patients still have to appreciate that that's right for them and then feel motivated to move forward. And so if we can't present that the outcomes show the benefits vastly outweigh the risks for that patient, then it's hard for us to do behavioral counseling. So we've got to be able to have these outcomes in a way that allow us to do that. Increasingly, though, especially with medical devices, I think we fall into the second category, where shared decision-making is most easily applied to preference-sensitive decisions, where both the clinician and the patient agree that equipoise exists between different options, and decision support helps patients think through, forecast, and deliberate those options. So at the end of the day, we may not have outcomes that tell us exactly what is the right choice for this specific patient. What we want to do is be able to help create a discussion around whether a treatment that may be good for one person may not be good for another, and be able to have the data to do that. I also think that the concept of outcomes also applies to, do we have kind of the data to be able to engage and then activate and help patients deliberate and discuss what are values concordant decisions for themselves. And we actually have measures for levels of engagement, levels of activation, and those are important. So I'm going to talk about left ventricular assist devices or artificial heart technology because I think it's a great case study to illustrate with medical devices for heart failure how the outcomes are so important. So, 50 years ago, artificial heart technology was pie in the sky, and here we are today where left ventricular assist devices are now done in over 4,000 patients a year in the United States, which has outpaced transplantation, and even one of our vice presidents has benefited from this technology. This is a fast-moving field, which also challenges the data collection and outcomes measurement. So this is from the New England Journal of Medicine in February of this year, and you can see that there was one article on the new HeartMate 3 device, which was studied in the Momentum trial. And there was a second article on the HVAD device studied in the Endurance trial. So this field, again, is moving forward fast, and we need good data. The other reason mechanical circulatory supported left ventricular assist devices are such a great place to study outcomes measurement is that there is almost nowhere where there is such high risk, high reward, right? This is where the benefits are huge and the risks are huge. And so being able to measure those and convey those in a way that people can kind of weigh is critically important to the therapy and the way that we counsel people. So let me give you some examples of how we've tried to take the outcomes data from the scientific community and digest it in a way that patients can potentially comprehend, gist, and then make a decision about. So left ventricular assist devices for people essentially dying of heart failure can have fairly significant survival advantages. So when we did a systematic review of the data available, which most of it only goes out to a year, so we really can't even say what happens at 5 years very well. The best data out there is that without therapy, about 80% of people will die and 20% will live. And with the therapy, about 20% of people will die and 80% will live. And the way that this looks on a Kaplan-Meier curve, which I think would be difficult for a patient to understand, is that at a year we really move people so that their survival more than doubles. So the number needed to treat at 1 year is that if we put in 2 LVADs, more than one life is saved on average. That's pretty impressive, and that's pretty important to most patients. However, patients not only want to live longer, they want to live better. And so how do we convey that to patients as well? Well, we also provide quality of life data to patients, and we're going to have some discussion today about what are the best quality of life measures in terms of general quality of life measures, disease-specific quality of life measures, as well as functional outcomes and other things that should map to quality of life and independence. But what we found when we went to patients is that presenting a whole slew of scores with scales that are not necessarily easily digestible is actually very challenging. And so we ended up with this figure here, which essentially takes the KCCQ data from the trials and shows that on average patients move from a KCCQ score of 28 to a KCCQ score of 70 among those who live. So a couple of key points about this. One is that I think that this is a very digestible way for people to take in that information. And it's on a scale that I think makes sense. Rather than 105 down to 0, it's 0 to 100, which I think is important. And then the last is we spend a lot of time trying to parse out very minor differences between outcomes. And what we find for most patients who are trying to take in all this information is that it's actually the big picture that's far more important than the very minute details. And I think a lot of times we split hairs over which quality of life measure we want to use. And if you actually look at the data for all these diverse measures that kind of map to quality of life domains or health status domains, they actually kind of all move in the same direction, and that's what patients care about. The other is that there are always trade-offs, and there are always downsides and always risks. And so we present on the top what are the average benefits, but people also care about what are the individual bad things that might be able to happen to me, and we need to be able to convey that as well. So with left ventricular assist devices, there are plenty of bad things that can happen even though the benefits are quite impressive on the whole. So we talk about hospitalization because it is important to people. It maps to independence, it maps to symptoms, and it also maps to prognosis, and then it maps to costs, not just for Medicare or for society, but it also maps to out-of-pocket costs for patients. Bleeding is a major problem for these patients. And so understanding what are the specific things that could happen and what are the frequency of those is important to patients. Stroke is a big downside and the major cause of death for patients who do get a left ventricular assist device. And so talking about this is important. And most people think differently about stroke versus bleeding, even though they both may decrease quality of life and even survival. Talking about device-related infections is also relevant, as well as what might happen to these devices that could then affect the patient. And then I think it's also relevant to think about the fact that sometimes therapies, they work on average, but they don't always work. And so one of the things patients have told us is that they've gotten a left ventricular assist device with the promise that their heart failure would go away, and yet about 18% of people continue to have very significant heart failure due to right ventricular dysfunction. So that's important because of the disappointment and the expectation management. And so measuring all of these outcomes is important to people if they're going to weigh all these trade-offs. So I don't think there's one single measure that's going to give us the answer or give patients the answer. The other thing that's really interesting about left ventricular assist devices is that caregiver involvement is really important, and patients care about that. Patients, one of the most important things to patients who are older, who are suffering from heart failure, is they don't want to be a burden. And so if we don't measure what's happening to caregivers, then we're not doing our job to help patients make good decisions that are important to them. And this is some work we did where we looked actually just at 8 sequential patients at our institution. Actually, Dr. Redberg published this and championed it. But essentially what we found is that 8 people with a left ventricular assist device, when they died, had pretty horrific deaths. I actually think that the deaths for many of them were not particularly troublesome for the patient, but were actually more troublesome for the caregivers. And so understanding how this affects the people that, the loved ones of the patients making the decisions is critical. The other concept or contextualization I want to give you is that we like to talk in these very discrete kind of hard outcomes. And if you really sit back and spend time with patients about how they're making decisions, that's actually not the way that they often approach this. So as we today talk about what do we want to measure and how are we going to help patients going forward, we also have to think about what is it that's going on in patients' heads. And I think people like Dan Kahneman and the whole kind of literature around the way people make decisions has been informative. So here you have a patient who's dying of heart failure. They're very symptomatic. They've been in and out of the hospital, and you offer them a left ventricular assist device, which, like I said, on average may offer great benefit, but comes at significant cost and resources, and also may have not a good outcome for a minority of patients. This is high stakes, it's complex, and it involves caregivers, but it's also extremely emotional. And at the end of the day, uncertainty reigns in a lot of these high stakes decisions. So we may be able to talk in averages, but we also need to talk about the extremes in the individual course that each patient may undergo. And then finally, there are a lot of cognitive biases in the way that people process the information. So they may not weigh it rationally like we do. They may actually be very affected by whether they either had a relative die of a gastrointestinal bleed or had a relative die of heart failure or had a relative die of stroke. The other thing we find is the way that people make these decisions. And in talking to patients, there's a real dichotomy. So we have some patients who are like us, I think. They're very reflective. They use a utilitarian approach. They weigh the survival data. They weigh the outcomes data. They weigh how this is going to affect their family and how much it's going to cost. And they try and put all that together and make a decision. But what we saw is that many people approach this kind of from a simplistic emotional view, and the thing that really determines whether they want the therapy or not is whether they're comfortable with death or not. And if they're not comfortable with death, survival becomes dominant over everything else, and kind of fear of death can change the course of how they're deciding. And so they become very automatic in their self-preservation, and they're actually not necessarily interested in a lot of the nuances. And so I think those patients still need to be counseled. They still need outcomes data, but the way that we present kind of what are the benefits and risks is important, but also is important how we do it. So helping patients understand that just because their average survival is better, if they get a left ventricular assist device, that's a much more aggressive approach to therapy. And so while they may do well, when they don't do well, there are a lot of burdens in the way that they die, and that is also something to be fearful of. The other comment I want to make is that I really do think we're moving forward in the way that we're approaching this. So there's a lot of good discussion out there now that informed consent is very broken, that having legalese kind of long paper that people sign that really doesn't do much to help them understand in gist what's going on with these medical decisions and the various options they're facing. I think we're moving in the right direction. The other, again, is, like I had mentioned before, is Medicare cares about this. So the National Coverage Determination for left atrial appendage occlusion, as well as the NCD for lung cancer screening with CT, now actually mandates that shared decision-making take place, that there are people who aren't particularly biased involved in that counseling, and that patients use tools that help them kind of process this information, and those tools are specifically not an informed consent document like this. The other problem, I think, where Medicare and this community can make a difference, is actually helping to make sure that patients are getting the right information. And to some extent, I think we've not done a good job of asking for that for our patients and the people that we either care for or we cover their therapies. So because we've said that we're not going to feel responsible for really educating our patients, what's happened is that marketing, which is fine, has really filled the void of doing that. And so in left ventricular assist device therapy about 5 years ago, there was essentially almost nothing except for advertisements for people to understand their therapy and what they should do. And so we looked at what was available out there for patients a few years ago, and not surprisingly, 97% of the information available to patients talked about the outcomes that related to benefit, but only half of them talked about the outcomes related to harm or risks. And so it's incumbent upon us not only to make sure that we're measuring the right outcomes, but that we get those outcomes out to patients, and we have the infrastructure to do that. And I think we all have various ways that we can help make that happen. One of the ways that we're doing it is through patient decision aids or tools. I think these tools take the outcomes data that we're talking about, what we should measure on today, and decide what is medically reasonable, and then make sure that knowledge is transferred in a way that makes sense to patients and is balanced and is not overwhelming, and then also solicits patients' preferences. So one of the key features of a good decision is not only making sure that patients are knowledgeable and understand the range of outcomes and what can happen, but also ask them to reflect on what their values are. And increasingly, I ask patients to reflect on, is it really survival alone that's most important, or is it really living with a good quality of life that's more important? And often what maps to that is, am I an aggressive person who doesn't mind interfacing with the medical community and am willing to take some risks for a possible overall average benefit? Or am I somebody who is happy with life, does not want to see my doctor, does not want to be in the hospital, and does not want to take a lot of risks? And I think sorting through those values with patients is almost as important, essentially, as making sure that they have the outcomes available to them. Only in merging the values with the outcomes for the various options can we really help patients make the right decisions. So we've done this for left ventricular assist device. This is kind of a classic approach to developing a decision aid. So first off, there's a needs assessment. What's out there? What do patients need? What do providers think is needed? What do payers like Medicare actually think is needed? And then we kind of cull that information and we develop an initial kind of tool that tries to put together what is the problem, what are the options, what is the data for and against each option, and what are the values that are relevant to that information. And then we do an iterative process where we go back and forth with patients, providers, caregivers, and other stakeholders to try and distill this down into the most important information in a balanced way that then helps people approach this. And ultimately, it really comes down to what are the outcomes for each option that are important, and how do people use their values to sort between that. The other thing I would say is that we're going to talk today all about kind of these formal averaged outcomes. And what's really interesting is that patients care a whole lot more about what does an individual N of 1 course look like. So I may say that your average survival increases from 20 to 80%, and your average health status increases by or doubles if you survive. But what patients really want to know, rather than that list, is I want to see somebody who went through this and what did it look like for that person, to really ground the outcomes in what's the actual experience that people see. And the only way that I figured out how to do this, other than presenting the data as I showed you before, is actually to gather a group of different people who have taken the various options and then have experienced different courses with that option. So you can see here, these are a couple of the patients who have agreed to be in our studies. So one patient had a very good outcome, one patient didn't have such a good outcome with LVAD, and to show their individual experience and the contrast is helpful. But also just as important is to show people who chose not to pursue left ventricular assist device. So on the right is one of my patients who said, I don't want to get a left ventricular assist device, this is why, and this is actually what my life looked like after I decided not to do that. So we need to be able to take those the data and the outcomes and present them, but I think people also want to know what does that look like for a single individual. I was listening to a TED Talk actually this morning on the treadmill, and they said, you know, every patient is an outlier, right? There is no average patient. So we can't pretend that if we collect a whole bunch of outcomes data and just give it to people that we've actually done our job. And this is one of the ways to collect data, I think that's important, but it's got to be balanced. We can't do what I think sometimes advertising does, which is to say, you know, I bought these shoes or I got this left ventricular assist device and everybody does well. What we need to do is collect not only the outcomes for large groups of people, but also what are the specific courses that people can have after they make a decision. So we're actually also spending a lot of time trying to figure out, once you do all that and you create these tools, how do you get them into use? And I think PCORI has really struggled with this. In the first couple of years of PCORI, about 60% of the project developed decision aids to create tools to help people make the right decision. But none of these tools, or not none of them, but many of them are not really being used. And so the work that we've done that's been funded by PCORI has spent a lot of time trying to think about, okay, now we've worked really hard to develop these tools with all the outcomes data that this community has collected, try and put it in a form that's digestible and accessible. How do we make sure that that gets out to the patients in a way that's not only good for them and that they can use and is practical, but also doesn't add to the provider burden of trying to do what they do? Hopefully actually makes it easier for us to have these discussions going forward. And so we're actually finishing up a study. We just closed enrollment in February, so I don't have final results, but we had 6 sites with some of the people in this room and actually had an incredible experience. We actually over-enrolled in this study because everybody was so excited to participate. And I think that speaks a lot to the need in terms of how do we get these outcomes out to people. We actually use the RE-AIM framework about, you know, does the decision aid, does it reach the patients? Does it actually help improve their knowledge and their value treatment concordance in the decisions they make? But also on the provider and the shareholder side, are people adopting this? Are they implementing it in a way that makes sense and was intended? And finally, now that we've stopped the study, are people maintaining the use of these decision aids that talk about the outcomes? And I will tell you what's great is all 6 sites actually are continuing to use this, and there are really only over 100 sites in the country that use left ventricular assist devices, and we've had organic uptake and kind of natural implementation of these decision aids at another 20 sites. So that's, I think, encouraging. The outcomes are, you know, talk about knowledge, but it also talks about conflict, decisional conflict, decisional regret, stress and anxiety for patients, what caregivers are experiencing, and then control preferences. And one of the things that we see is patients will say, Doc, I just want you to make the decision for me. And that's mostly out of ignorance and fear, I think. If you engage patients with these kind of decision aids, what we find is that the activation, the desire by patients to be involved in their decisions actually goes way up, because now they're empowered to say, oh, I actually can take all this outcomes data, understand it, and then match it to my values, and now I no longer want you to decide for me, I want to decide for me. So we've got to be able to do that with the information that we have today, is give it to patients in a way that they can use so that they feel empowered to make value concordant decisions. And we see that people's values actually change. The caregivers think that we should be absolutely aggressive, and they fear the death of their spouse. But actually, when you go through this process and show them all the trade-offs, all of a sudden they actually can realize, maybe I don't want to be that aggressive. That actually doesn't match the true values of myself or my loved one. And we will hopefully have some of these results for you in the future, but I think even though we don't have them for you today, I think they inform the discussion going forward. So we've been developing these decision aids not only for left ventricular assist device, but we have them for implantable cardioverter defibrillators, which I think are really important because they don't improve quality of life, they only improve survival. And we are also working on left atrial appendage occlusion devices as well as TAVR devices going forward. And hopefully this will be helpful for the community. So thank you again for letting me talk about this work. And I just want to summarize by saying, if we really want to help patients make informed decisions about new heart failure technologies, then we need their input from the start. We need to think about the patient perspective when we're measuring the outcomes. From the perspective of what are the patient's, the important questions to the patient, what are the important outcomes to the patient, and how can we give that data in a form that patients can understand and incorporate into their decision making. And I think actually, thinking about the questions, the outcomes, and making sure that it is accessible to patients really should help inform the discussion later today. So thank you again.
Thanks so much, Dr. Allen and Dr. Lawrence, and you've really given us a lot of new information, I think, to think about for this and other technologies on patient decision aids, and we'll look forward to hearing more from you. I also have to thank all of the speakers for not just staying on time, but some people were ahead of schedule, and so we will use that time to stay ahead of schedule. But I think we can now take, we'll say, let's see, what time is it exactly? It's a few minutes before 10. We'll come back so it'll be a 12-minute break. We'll come back at 10:10, and then we'll start with the public speakers scheduled and open public comments. Thank you. Really good.
When the schedule gets up, Charlie's going to bring me a remote and I'll control that. Better than the timer that we used to And we only have 3 people signed up for the open public. So I think really we're going to probably be going to lunch around. I just want to say hello. How are you? I think we'll probably go to lunch around 11:30.
Okay, you want to go to lunch earlier? We can do that.
Down something and right to the left-hand side.
So you see our slide?
Yeah, oh yeah. It's, which one, the PAD? We have a couple of people who like the peripheral stuff, so we try to shift it to them. Like I've got a guy in the unit right now who crashed, has already had 2 strokes in the past, and we couldn't get him
It seems like it. Okay. They just brought him up again now.
Sherry said that the presentations were really good.
Just go to the site for the meeting. Okay.
Just go there, and that's where they are. And then that's after the meeting, that's where the voting questions will be as well, the results.
Oh, great. Okay. Terrific. So they're already up there. Go to the site
Can the panel please take your seats? Oh, okay, thanks.
I wanted to say, huh? No, it is real. I want to say
Yeah, that was excellent. Right. Tell us what patients are thinking and your experience. That was great. Thank you. We're going to start again. So I would like to welcome everyone back from the break. The panel, please take your seats. And we now have scheduled speakers for public comment. They have 7 minutes per person, and the first speaker will be Clinton Bronner, who is a clinical exercise physiologist from Henry Ford Hospital, and he is representing the Cardiovascular Research Foundation. Dr. Bronner? Okay, if he's not here, maybe we'll go to the second person and switch it. Okay, if Dr. Bronner is not here, then I'm going to go on to...
Oh, here, he's here. I apologize for that. Thank you. It got quiet and I knew I was in trouble. Good morning. It's my pleasure to be here on behalf of my colleagues here to talk about exercise as a measure. We really appreciate the opportunity given to us by the panel to present here today. So here are our conflicts. For myself, I'm an employee of Henry Ford Hospital. I perform cardiopulmonary exercise tests and I also serve as a core lab for multi-site clinical trials, and our current contracts are shown here. So the earlier presenters did a lot of my work, 20 slides. I'm not going to cover that in 7 minutes, and it appears I'm not the only presenter that has kind of set that model up. Heart failure is a challenge. These are patients that a cardinal symptom is exercise intolerance. They come into the clinic saying, I can't do this, I can't do that, I can't do what I used to be able to do. So we've heard quite a bit of that thus far. That means they're affected by the activities of daily living. They can't do what they used to be able to do. Heart failure trials have done a great job. We've got smart people working on this challenge, as we've heard already this morning. Mortality rates are gone down, but still high. Continuing to use hard outcomes like hospitalization and mortality is a challenge. It takes a lot of patience and it takes a lot of time, which is a lot of money and a lot of demand on both health systems and patients. So the current presentation, or the next 6 minutes or so, is addressing question 4. How confident are you that the functional assessments, 6-minute walk test, the VO2 max, and it's been thrown out already a couple of times, I'll give us at least a very quick definition for those that may only know it cursory, and ventilatory threshold. 6-minute walk test. We've kind of heard this a bit. It is a fairly simple test, but a simple test can be confused and done wrong. Dr. Pena talked about how she delivers the KCCQ in her clinic, that she has someone unfamiliar with the patient, unfamiliar with the care of the patient, deliver that test to them. Well, the same kind of challenges are presented with exercise tests like the 6-minute walk test. The 6-minute walk test is done in a hallway. There's very defined standards on this, and we simply ask the person to walk as far as they can over the course course of 6 minutes, with the idea being that if your symptoms are so limiting, they may limit your ability to walk at whatever your normal pace might be. Originally developed in patients with pulmonary disease, it's been applied to patients with heart failure, pulmonary hypertension, and others. The cardiopulmonary exercise test, gone by a couple of names, but this is a more formal test. We bring the person into the lab, we put them on a treadmill or potentially ride a bike, and we have a mask or mouthpiece on them. And the best example I can give you is if you've seen the Gatorade commercial where they've got athletes sweating different colors, there's a couple images of an athlete running on a treadmill with a mouthpiece in. That's what we ask some of our most severe patients with heart failure to do. And I've heard some of the critics in the past, patients will do it. It's putting it in the context, maybe a patient-centered context, that describes the what and whys, what we're doing, whether it's for the clinic or for the research for a clinical trial. Not only are these two tests very different in their conduct, but they're different in the measures they might be presenting. The 6-minute walk advocates would suggest that it's more representative of daily living. This is how people live throughout their day, the pace they walk at the grocery store, how fast or slow they walk to and from their car in the parking lot. And then those who are in the cardiopulmonary exercise test camp would say it's much more objective. We get a lot more physiologic data. Both might be true. So for the cardiopulmonary exercise test, it's been thrown out already. I'd like you to think about for a moment. Dr. Pena threw out an example of a patient with a VO2 of 14. VO2 is the volume of oxygen the patient can consume. The more oxygen, we're back to high school biology, the more oxygen you use, the more energy you create. We need oxygen to do energy.
1 minute remaining.
Thank you. Patient with a VO2 is very limited. Imagine a VO2 of 14, they're working at 50% of their ability just to walk down the hall. Does VO2 correlate with, improvement in VO2 correlate with outcomes? It does. HF Action showed that a 6% increase in VO2 when adjusted for other independent predictors was associated with 5% lower risk for all-cause mortality. Really important. Many trials have showed improvement in VO2 that also correlated with outcomes. VO2 is, as well as 6-minute walk, requires professional oversight, most commonly done with a core lab. There are other measures to the cardiopulmonary exercise test. The anaerobic threshold and ventilatory anaerobic threshold is one of those, and they also can be useful and shown to be important to outcomes.
Thank you, Dr. Bronner.
Thank you very much for your time.
Thank you. The next speaker is Bekem, I hope I've said that correctly, Boskert. He's the Mary Ann Gordon Kane Chair at DeBakey VA Medical Center and directs the Winter Center for Heart Failure Research. He's representing the American College of Cardiology. Dr. Boskert. I'm so sorry.
That's no problem. I'd like to thank CMS for the opportunity to present on behalf of American College of Cardiology. I'm hoping to have my slides up on the monitor. And in terms of my employment, which has been already stated, I work at the VA and in Houston. And I do enroll into clinical trials, and American College of Cardiology has no conflicts to disclose regarding the presentation. In the next few sessions, we're going to collaborate. I, as a representative of American College of Cardiology, will tackle question 1, and representatives from SCI, AHA, and HFSA will be tackling some other questions in detail. And the first question, hospitalizations, are they important? The answer is absolutely yes. They're the holy grail of the endpoints in our heart failure clinical trials, but I'm going to take it another step. We need to refine as to what we demand according to patient's journey and the device type. This has been alluded to. For a patient who undergoes a technology or a device that may be associated with morbidity or even mortality or a long length of stay, they may not have time to be readmitted. Thus, days alive perhaps may be a better concept. Freedom from hospitalizations and overall survival may be a better concept. Second concept, the mid-component, equivalent, perhaps treatment strategies with IV diuretics as an outpatient, critical as well as, especially when we have secular trends for reduction in readmissions, when we're giving the treatment as an outpatient. So the middle silo, which is heart failure hospitalization or equivalent events, would be critical for individuals with congestion. and where treatment strategies are being deployed more at the urgent care setting. The third silo, all-cause hospitalizations are critical when we have devices that may be associated with morbidity or even other competing diagnoses, such as hypertension or renal failure or bleeding or atrial fibrillation. And this may be an important concept in HFpEF. And the patient's journey is critical. For a patient in shock, which is on the left side of the panel, acute decompensated heart failure, what's the duration should we target? Perhaps short, maybe in-hospital mortality or 6-month rehospitalization rate. Whereas for a patient hospitalized without shock, perhaps we're going to look at a 30-day readmission rate or a 60-day. For a patient with stage C, we're going to look at perhaps a 1-year event rate. For stage D, end of life, maybe we're going to look at shorter endpoints. The next concept that we were questioned is combining endpoints. It's important, perhaps when the event rate is low, for us to be able to achieve the sample size, but the direction of the endpoints need to be concordant. The other reason that the combined events are important are it gives a more holistic perspective, not solely one endpoint, perhaps the patient's perspective a bit better. And the global ranking approach, where the hierarchy of the events will need to be taken into consideration. If we're valuing death, then the death will need to be a higher ranked endpoint than the others, vice versa for an end-of-life patient. The other yin and yang component of devices, there needs to be definitely a reflection of the device's efficacy. Not solely just heart failure hospitalization. So we need to be able to see that the device is actually performing of what it's supposed to be doing, freedom from complications, along with maybe clinical endpoints. And I'm going to give 3 examples as to when the hospitalizations may not be adequate enough. This perhaps is a busy slide, reflecting the summary of what we know with shock recovery gadgets in the acute heart failure setting, most of which have not looked at heart failure hospitalizations, was not able to demonstrate survival benefit, but was able to demonstrate hemodynamics benefit. Second, we have devices out there that are targeting heart failure hospitalizations. The thing that needs to be kept in mind, it is not going to be the CPT of the insertion that is going to make probably the reduction in hospitalizations, but the effort that goes behind the monitoring and up-titration of medications. Thus, when Medicare looks at the concepts of reimbursement for these entities, the effort or the up-titration of the medications will need to be taken into consideration. And other concept that will need to be taken into consideration is the secular trends of what's happening in the technology. The clinically indicated, this is an ICD slide, are moving very rapidly in revising, refining their technology that will look similar to the other, perhaps approved devices. They will be able to do certain entities with algorithms or sensors or upgrading. So the Cadillacs are moving very rapidly and thus will need to be taken into consideration in the background. And we need to be cognizant, and when we are only looking at hospitalization, which in an ultrafiltration trial were not able to be demonstrated in an NIH-sponsored trial, we were able to see a signal from the adverse events when combined with the clinical events, and we had other primary endpoints, such as looking at the rise in creatinine, weight loss. So we need to go out of the box with technology and see what the technology is targeting, which is a device's initial efficacy, and then look at clinical endpoints in conjunction with perhaps the adverse outcomes. Secular trends mandate the necessity of controlled trials or controlled setting because in the background, as seen on this slide, due to a variety of other interventions, the heart failure hospitalizations are going down and maybe the OBS setting or urgent care setting is going up. This is a slide from Lynn Warner Stevenson's group showing that the patient's journey matter. If we're going to tackle hospitalizations, perhaps end of life, which is seen on the right side of the panel, these inevitable episodes of care now that are transitioning to LTACs and SNFs may not be preventable. And maybe that's not what's meaningful for the patient or for the healthcare providers or public.
It's time to wrap up.
To finalize, for acute, perhaps with shock, we may need to have in-hospital events, maybe look at a 6-month follow-up. For without shock, maybe a longer follow-up, chronic heart failure setting, maybe freedom from hospitalization and survival. Stage D may need to have more qualitative functional assessments. So in summary, one endpoint would not be appropriate for all technology. Technology needs to fulfill efficacy, device safety. Endpoints should differ according to technology target profile and patient stages. Composite endpoints need to be concordant, and time to event approach may mask later events, and outcomes should be comparable in direction and magnitude, and safety and efficacy should be considered as well as efficacy. And background changes in care mandates us to look at what truly we're going to target, both for clinical trials and for reimbursement. Thank you.
Thank you, Dr. Buskert. Next is Srihari Naidu, who is Director of Hypertrophic Cardiomyopathy and an interventional cardiologist at Westchester Medical Center. Dr. Naidu is representing the Society for Cardiovascular Angiography and Interventions.
Great, thank you for having me. It's my pleasure to be here and represent the Society for Cardiovascular Angiography and Interventions. My name is Hari Naidu. I'm a little bit, I guess, unique in the field of interventional cardiology in that I think I wear two hats, and it's one of the reasons why I'm here today, is that I run a hypertrophic cardiomyopathy program, which obviously is a form of heart failure with preserved ejection fraction, and I'm an interventional cardiologist. So a lot of what I do in my day-to-day life is really understanding the intersection of both heart failure and interventional cardiology, and looking at interventional cardiology more in terms of advanced hemodynamics and techniques that we could promote to improve the heart failure state. That's where my career has gone. I have some advisory boards that are fairly modest, relevant to heart failure. These are the questions you guys already know, and I know we have very limited time, so we'll move past. So I want to talk to you about the Interventional Heart Failure Work Group. This is the group that we discussed this topic, and I was very happy that CMS is looking at this topic because it is fundamental to the reason that interventional heart failure is here. The concept was enlightening to me that many times interventionalists are viewed as individuals that approach things anatomically. We see a blockage, we fix a blockage. We see a valve leaking, we fix a leaky valve. But fundamentally, I think we have to change, and I've been promoting this amongst our colleagues, that we are really interested more in the heart failure state. Many people are on medications, they're surviving their heart attacks, they live with their heart failure, but it may not be a very good quality of life. In fact, it's a miserable quality of life for many people. We just heard about the multiple medications they take, which is true. That is a morbidity for patients. And we've also heard about how they struggle with rehospitalization. So interventional heart failure is a concept that there are oftentimes device-based strategies that we believe can minimize the medications, improve the anatomy, and ultimately lead to meaningful improvements in outcome. And importantly, not all of those outcomes are mortality. So we believe that most therapies that have improved mortality result in more patients living with heart failure. Current and future therapies must focus not only on mortality, but perhaps on heart failure and related outcomes. Patients and physicians value quality as much or more than quantity of life, especially as patients age. We must be working as part of a team, not just as interventional cardiologists. And advocacy, which we're doing here, education and further research are necessary to help foster technological advancements to reduce the burden of heart failure. So the search for meaningful endpoints. So when death occurs with high frequency, it's very obvious that we can improve the mortality. Many of our therapies have markedly reduced mortality, such as ICDs, however, leaving the patient with ongoing and progressive heart failure. Clinical events related to the heart failure state have emerged as accepted secondary targets. It's very easy to see how this is the case in aortic stenosis, where once symptoms emerge, within 3 years, you're falling off the cliff. And so therapies that can improve that will obviously have an impact on mortality. You see here, this is data from the SAPIEN, XT, and CoreValve trials looking at TAVR and AS. You very clearly have a mortality benefit that approaches 3% within the first 30 days and then actually enlarges as time goes by. So that's a very obvious benefit. But the story is different for other technologies. This is mitral valve disease, and is it reasonable to use mortality as a surrogate here? Probably not. If you see, surgical approaches have really not improved survival in the case of mitral regurgitation, and that doesn't mean it's a failure. If you look at secondary MR, we have lots of reasons why if you fix the MR, you may not see an immediate benefit in these patients in terms of mortality. Looking at the Everest 4 trial for MitraClip, we saw the same thing. Death is not impacted in the near to short term. MR is impacted in the near to short term to near term, and it is done with less risk because these are percutaneous procedures. But the benefit is quite meaningful. You see improvements in New York Heart Association class that are comparable to surgery without surgery, and this is seen at 48 months, which I think is a reasonable short-term horizon. So in terms of the path forward, we do need novel hard endpoints that are required. And I use hard in quotes because they're not mortality oftentimes. Maybe we want to look at days alive and out of the hospital, or heart failure rehospitalizations, or total hospitalizations, a measure of efficacy. And this has intrinsic value to all parties, including everybody in this room. We are all patients, we are physicians, we are family, we are healthcare system, and we are responsible for all of this. And the surrogate endpoints have to make sense. We have to show effectiveness. This is a device and disease specific, for example, reduction in MR in the mitral clip. And importantly, I think we are at a stage where we must face the consequence, or the point here, that not every treatment must save lives. We do have treatments that perhaps improve the quality of people's lives and maybe are neutral or perhaps even negative sometimes in terms of the quantity of life. So examples where mortality benefit would not be a realistic target: the ESCAPE trial, CardioMEMS. These are devices that do have meaningful benefit, we believe, but it may not be in mortality, certainly not in the near-term horizon. Appropriate targets for these would be surrogate endpoints of heart failure, which would be reasonable predictors of improved quality and maybe a reasonable predictor of quantity of life going forward, but we cannot power trials to determine that. So what would be meaningful surrogates in our world? For heart failure with preserved EF, perhaps 6-minute walk test, biomarkers, and whether you escalate or de-escalate therapy, medication therapy. I think that's important, not just escalation, but de-escalation needs to be considered. Heart failure secondary to MR, reduction to trace or 1 to 2 plus MR, the same other markers. Perhaps LV volumes are important mechanistically in that situation. And the same with reduced ejection fraction, where volumes become important, as well as de-escalation of therapy and failure to escalate therapy. Surrogate endpoints should ideally be part of combined endpoints and are generally not sufficient as standalone variables. We believe that. And you should ideally demonstrate congruence between hard endpoints and surrogates to confirm safety of devices. So further discussion, it is important to note that the aforementioned surrogates in general have not been proven prospectively, and I think it's very important to pick some of these and determine which ones we're going to make the gold standards going forward so that we can continue to innovate. And we would encourage those trials that define these variables and stand behind them as important variables for all of us. So to summarize, except for heart failure etiologies with high mortality, most others affect quality of life primarily, and this is a very, very important target. Hard endpoints will need to include novel endpoints such as rehospitalization or days alive and out of the hospital, meaningful to every stakeholder. Additional surrogate endpoints as part of combined endpoints will be necessary to prove improvements in heart failure syndrome that are technology and disease specific. Importantly, there is no one-size-fits-all, and a tailored approach to selecting surrogates will be required, understanding that devices should remain low procedural risk. So that means that as you're looking at different devices in this space, we need to look at how they may work and how they may impact heart failure specifically. And finally, effects on mortality should be tracked as registries over the longer term, understanding that the goal of days alive and out of the hospital may not always relate to reduced mortality. So to conclude, I do believe that we all want to applaud, Sky wants to applaud MEDCAC and CMS for looking beyond mortality as a meaningful endpoint to address the main clinical outcomes in heart failure, i.e. morbidity rather than mortality in today's world, to prioritize quality of life as much as and perhaps more than quantity of life, consistent with palliative care principles, and to facilitate advances in technology. And that's why I'm here today. As SCAI, we work hand in hand with our patients, with other colleagues in cardiology, but also with our industry colleagues, because we need the innovations to make meaningful differences. And it's not all about mortality. We do believe that most of these will translate to mortality if we pick the right variables. Thank you very much.
Thanks very much, Dr. Naidoo. Next, I'd like to introduce Dr. Nancy Schweitzer, who is from the Sarva Heart Center in University of Arizona, and she is representing the American Heart Association.
I'd like to thank the panel for allowing me to be here on behalf of the American Heart Association. My goal is to discuss quality of life in particular. As an endpoint, I have a career also in clinical trials research, so I do have some disclosures related to that. So I'm here to address quality of life, question number 3. And particularly, I'm going to focus on what I would argue is our best quality of life measurement tool presently in heart failure, which is the Kansas City Cardiomyopathy Questionnaire, KCCQ. On behalf of the AHA, we believe that disease-specific quality of life measures do reflect the patient experience when they are well designed and capture exactly what is most meaningful to our patients, and thus represent a very important endpoint in our trials. The KCCQ is validated in almost all heart failure states, including HFrEF and HFpEF. It maintains validity in the presence of other morbidities, which are common in our patients. A change of 5 points in this scale is considered clinically meaningful and has been shown to be clinically significant when followed. It's the most sensitive questionnaire to change and is certainly more sensitive than some of the less disease-specific questionnaires. A meaningful primary health outcome must be clinically meaningful in its own right and important to the patient. And I believe quality of life outcomes meet this definition of a meaningful outcome and are a sensitive and specific tool for testing interventions. I think it's thus absolutely reasonable that quality of life can be a standalone primary health outcome in some research studies, providing safety and risks of the interventions are also being measured. Symptoms and functional capacity have been standalone outcomes for therapies in other cardiovascular disease states, including angina and peripheral vascular disease, pulmonary hypertension, and certainly I think it's time to move this into the arena of heart failure as well. Failure to include a measure of quality of life, I would say, is a failure to comprehensively study an intervention. If we're looking at particularly technological innovations and we're not looking at the impact of those technologies on our patients, I think we've failed our patients. So it's critical that these be included as endpoints. I don't think they should be part of composite endpoints because they are qualitatively different from less subjective endpoints such as hospitalization or death. So they should be their own standalone endpoints in our trials. We're obligated to understand the impact of technology on our patients' lives, and these sensitive and specific questionnaires that we've developed do just that. So we would strongly support an actual requirement for some assessment of impact on quality of life as an adjunct to other endpoints in design of technology trials. With reference to the discussion questions for this particular aspect of the inquiry, there's little evidence that other questionnaires improve understanding of therapeutic burden associated with heart failure beyond what's found in the KCCQ, and probably the more general questionnaires such as SF36 and EQ5D are less sensitive in our patient population. Because we have such a good tool in heart failure, I would argue that that's the appropriate tool to use. To talk about length of follow-up, there are many device trials now, the VAD trials, the trials of CRT therapies in heart failure that show us that quality of life benefits are typically realized quite quickly in these patients. Typically, a 6-month period would be sufficient to detect improvements in quality of life. And in fact, going beyond that period, often quality of life outcomes might be contaminated by ongoing processes that were not impacted by the technology. So actually the short-term 6-month outcomes are probably sufficient for most technologies. Of course, when we're looking at a new technology, we have to imagine how that is going to work and impact and use that to inform our decisions in this respect. But to date, 6 months seems to have been adequate for most of our technology outcomes in terms of quality of life effects. I think when we're looking at quality of life, lack of blinding is particularly problematic because there's often a belief in the technology among all patients in the trial, and quality of life may well improve. We've seen that multiple times in heart failure trials with significant improvements in quality of life in placebo-treated groups. So if quality of life is a primary outcome, I think it can only be used as such in a blinded trial. And then finally, in terms of talking about balancing adverse effects, obviously, I think as Dr. Allen illustrated very eloquently for us, many of our technologies have risks as well as benefits. And it is important to understand the impact of the technology on the domains of interest to a patient. Different patients have different goals, and goals change as patients age, live with disease, and develop other limiting comorbidities. So ideally, a well-designed study will help inform our future shared decision-making around technologies. We've seen this as illustrated by VADS. We do this daily with atrial fibrillation and decisions to use anticoagulation, as well as our TAVR decisions. So we need to design our trials so that we get as much information as possible to make these informed decisions. And at the end of a trial, we should hopefully have detailed information about benefit and harm that will enable us to have the best discussions around technology with our patients moving forward. So in conclusion, we need to understand the impact of new technologies on the patient experience, quantify the impact of the technology on disease manifestations most important to each individual, and use that as we move forward to implement those therapies in the heart failure population. Thank you very much.
Thank you, Dr. Schweitzer. Next is Dr. Chris O'Connor, who's the CEO and Executive Director of Innova Heart and Vascular, Professor of Medicine Adjunct at Duke University, and President-elect of the Heart Failure Society of America, and he is representing them.
Thank you for having me here today, and I'm representing the Heart Failure Society of America and addressing question 4 on functional assessment in outcomes in heart failure. Here are my disclosures as part of being in clinical research. Well, I'm pleased that Clinton set the stage for us already in the first talk, and so the questions you're already familiar with. How confident are you that functional assessment would be an adequate endpoint? Should we include them as standalone, as meaningful outcomes, or should they be part of a composite endpoint? And I'll try to address this really through work as principal investigator of one of the largest clinical trials that had serial measurements of functional assessments. That was the HF Action trial, where we could actually validate, as Clinton showed you, these functional tests with clinical endpoints. So peak VO2, 6-minute walk. There are other CPET variables that are out there, gait speed. There's even shorter durations of walk and even exercise time are functional outcomes that could be used as important endpoints in clinical trials. These have been shown to be prognostically important, as Clinton showed you. This is an example from Steve Catane's work from HF Action on peak VO2, showing a nice gradient of peak VO2 reduction and worse outcomes. Actually, in our predictive Uber model, it turned out when we put all the variable of functional testing in the model, exercise duration was the single most important prognostic determinant of the mortality endpoint. 6-minute walk correlates with outcome. You've seen this. But in an analysis where we put all the competing functional endpoints into clinical modeling, you can see here on this slide that 6-minute walk performs well in comparison to peak VO2 and equally well to more complicated functional outcome measurements such as VE, VCO2 slope. So I think these functional outcomes are highly predictive. They're probably the peak VO2 and 6-minute walk, at least from the HF Action data, are the best independent predictors. And as I'll show you here, I'll skip over a couple slides from HF Action. As Clinton showed you earlier on this slide, the validation of peak VO2 as an intermediate endpoint, as a functional endpoint, was conducted in the HF Action trial because we had adequate number of morbidity and mortality events to show that the change actually correlated with these composite endpoints and mortality. So how would we integrate this into decision making? Could functional assessments outcomes be standalone endpoints? They could be a primary endpoint in highly prevalent disease states if we could exclude harm. But in order to exclude harm, particularly in diseases that have, where there are lots of patients, you have to do large trials. So you already then have enough information to look at the clinical endpoints. The example of angina drugs is a good one, in which many drugs were approved on reduction in symptoms and improvement of 1 minute improvement in exercise time, but they excluded harm in those clinical studies, and certainly acceptable in phase 2 studies. So the functional endpoint could also be used as a composite endpoint. Certainly in common diseases where event rates such as mortality are low, this might be a good use of the functional endpoint as a composite. In rare diseases, the functional endpoint could be a standalone or it could be used in a composite, depending on how sick or rare that population is. And the phase 2 studies, of course, the functional endpoint in a composite is appropriate. Remember that when looking at composite endpoints, you want to make sure that all the components are going in the right direction, and that's one of the challenges. Here's an example of a study that we worked on for the last couple of years, just published yesterday actually, where we used the global rank endpoint of 6-minute walk, CV hospitalization, and survival. And it allowed us to do a smaller sample size and look at a device in acute decompensated heart failure. And in this study, we were able to detect a signal in the HFpEF population, which is allowing us to plan for larger clinical studies. Could this be used as a primary indication? I think would have to be discussed further. So in conclusion, I think as standalone, acceptable in the small population cardiomyopathies for sure. You could never get morbidity, mortality in this population. And so what I'd like to say to the panel is that 6-minute walk and peak VO2 are probably our best functional studies that we could offer possible indication for use as primary standalone endpoint in highly prevalent diseases if we could rule out harm. It's certainly a reasonable primary endpoint in rare cardiomyopathies or very advanced disease, such as very class 4 heart failure. And the composite endpoint, I think, is an intriguing endpoint, particularly the global rank, in low mortality conditions and in special subgroups, perhaps in the very elderly or other conditions. Thank you.
Thanks very much, Dr. O'Connor. Next, our last speaker is Dan Shaber, PharmD, from he's Vice President of Heart Failure Clinical Research at Medtronic.
Thank you, Dr. Redberg, and thank you to the panel for the opportunity to be here today and discuss Medtronic's view about heart failure trial endpoints. Here's my disclosures. As everyone has said, heart failure care has improved significantly and morbidity and mortality remains significant. We agree with what's been said so far in terms of heart failure hospitalization and mortality being important endpoints. However, they're not always the most practical, nor the most feasible, nor the most efficient in terms of assessing heart failure outcomes. And so what we'd like to talk a little bit today about is the use of surrogate or intermediate endpoints. In order for these to be useful, they have to be meaningful to all stakeholders, patients, clinicians, providers, and payers. They need to be biologically plausible, widely available, and least burdensome. And of course, minimally influenced by bias and cost efficient for trial design and execution. Most importantly, they must be predictive of longer term outcomes and corroborated by real world findings. Two such notable endpoints are the clinical composite score and left ventricular end systolic volume, which has been mentioned a number of times. The clinical composite score has been around for more than 20 years. It's been used in more than 30 heart failure trials. And importantly, it looks at all conditions and each patient counts towards the endpoint in a trial. So it looks not only at worsening, but also improvement and unchanged. It has reliably predicted the outcomes of improvement in beta blockers, ACE inhibitors, and cardiac resynchronization therapy. And importantly, it has also detected disappointing results with endothelin antagonists and positive inotropic agents. Here's an example. So we took 1,600 patients from 5 randomized controlled trials of CRT and looked at their 6-month clinical composite score, stratified the patients based on improved, unchanged, or worsened, and you can see here that worsened patients had the worst survival, unchanged patients the next survival, and improved patients the best survival. Also important to note here is that although there's not a difference statistically between improved and unchanged patients in terms of survival, there is a statistically significant difference in heart failure hospitalization between all 3 groups. The second measure, left ventricular end systolic volume, has been mentioned a number of times. Some of its strengths are it's a standard routine echocardiographic measure of cardiac function. Dilation, otherwise known as remodeling, is associated with poor prognosis, and reverse remodeling, or decrease in the size of the left ventricle, is associated with improved prognosis. It's been a powered objective in pivotal heart failure trials. One of those trials was the reverse trial, which looked at cardiac resynchronization therapy in mild heart failure patients, New York Heart Class 1 and 2. This was a pre-specified objective, and we looked at patients who had a reduction in their left ventricular volume of more than or equal to 15% as compared to the rest of the patients in the population. And you can see here that this reduction in left ventricular end systolic volume showed a 68% reduction in mortality. Another important point about trials for us, right? So as a provider of therapies and devices and solutions to physicians and hospitals is the timely delivery of our therapies. With CRT, it was done based on intermediate endpoints. 453 patients followed for 6 months. And you can see here that the trial was completed and approval granted within 3 years. If we would have had to do a morbidity and mortality trial, it would have been 800 patients for more than 30 months. That would have delayed access to the technology by more than 2 years. And the costs there are not only the incremental costs of the therapy and the evaluation, but the costs in terms of lives lost and benefit lost to the healthcare system while therapies are under evaluation. And this problem continues to grow. So if we look at, we want to show an incremental improvement on top of, for example, cardiac resynchronization therapy and guideline-directed medical therapy. To show further improvements on top of that may take as many as 3,000 patients, which is a trial that we're actually doing right now. So in conclusion, the use of surrogate or intermediate endpoints such as clinical composite score and left ventricular end systolic volume for heart failure interventions are meaningful. They allow for accurate measure of treatment effect in an optimal time frame. They can be corroborated by post-market measures of long-term outcomes. They can be easily implemented and tracked, and strategic implementation may expedite access to life-saving innovations while improving lives and saving healthcare expenditures. Thank you very much.
Thank you, Dr. Sharber. Next, we have 3 people who have members of the public who have signed in to speak. They will each get 2 minutes, and I will just remind you to please state whether or not you have financial involvement with manufacturers of any products being discussed and who funded travel to this meeting. The first person is Norm Linsky. And next will be Maria Stewart, if you're...
Thank you. My name is Norm Linsky, and I'm the Executive Director of Mended Hearts. the nation's largest peer-to-peer support organization devoted to cardiovascular disease. I have no disclosures of my own. Mended Hearts receives educational grant support from Novartis and Abbott. I stand today representing Mended Heart's 20,000 members across the U.S. to urge that the patient voice is considered as part of the panel's deliberations. We ask the panel to consider that hospitalization rates alone are not a complete reflection of the overall outcomes of heart failure treatment. While hospitalization and medical benchmark testing are vitally important, outcomes measurement should also include emotional, psychological, social, and economic outcomes to assure that the treatment is resulting in improved quality of life. Including patient-reported outcomes in overall assessment of heart failure treatment is similarly vital. This includes symptoms, functional limitations, impacts on daily activities, overall well-being, and economic impact of the patient. We appreciate the opportunity to comment and hope that while CMS measures outcomes, the patient voice is included in assessment of heart failure treatment options. This is vital, and we request that the patient's voice be very carefully considered. Thank you for the opportunity to present these remarks on behalf of Mended Hearts.
Thank you, Ms. Dolinsky. Next is Maria Stewart from Boston Scientific, and the next and last speaker, if you want to come, is Cynthia Chauhan.
Thank you. Good morning. My name is Maria Stewart, and I'm the Vice President for Global Health Economics and Market Access for Boston Scientific Corporation, which manufactures and markets cardiac resynchronization therapy devices that may be indicated for heart failure patients. We appreciate the opportunity to provide comments here today, and we applaud the steps that CMS and the FDA have taken to balance the importance of clinical trial rigor with the need for timely access to new technologies through mechanisms such as post-approval study requirements, expedited approval pathways, and coverage with evidence development. In the case of heart failure, morbidity and mortality continue to be the most consistently used primary endpoints. The time and resources required to conduct trials with these endpoints are becoming increasingly burdensome as evolving diagnostic and therapeutic options have changed the profile of heart failure patients. Relying on completion of studies with these endpoints as requirements to determine coverage without consideration of other valid endpoints could unduly delay patients' access to care. When considering what endpoints CMS should utilize when reviewing heart failure technologies, Boston Scientific recommends the following. Focus not only on the traditional RCT endpoints of morbidity and mortality, but also on the following categories of endpoints: heart failure hospitalizations, all-cause hospitalizations, validated surrogate and functional endpoints, all of which have been discussed today. Acknowledge the importance of quality of life and patient-reported outcomes. These real-world measures are integral to assessing new heart failure technologies in light of ongoing efforts to improve access and quality, reduce cost, and improve patient satisfaction. Consider the length of follow-up carefully. The appropriate duration of clinical trials will vary depending on the type of diagnostic or therapeutic being studied. However, when considering cost effectiveness and comparing technologies, it's always critical to evaluate the lifetime cost horizon using accepted mechanisms such as Markov models, particularly given the longevity of some heart failure technologies. We urge CMS to consider and assess the total cost of heart failure treatment in all settings, including ongoing monitoring and related decision-making, as well as the total costs avoided by diagnosing and treating heart failure earlier. Finally, Boston Scientific encourages the MEDCAC to acknowledge that various technologies and diagnostics under consideration will provide either clinical or economic benefits, or both, to the healthcare system at different points along the care pathway. To truly assess the impact of novel technologies for heart failure, all associated outcomes at all time points must be given due consideration. Thank you for your time and attention.
Thank you. Next is Cynthia Chauhan, and if you could just state if you have any involvement and who funded your travel to this meeting. Thank you.
My name is Cynthia Johan. My travel, I'm a heart failure patient. My travel was supported by Abbott, but they had no input or influence on what I am about to say to you. I am here as the face of a heart failure patient to give you input on what it's like for us. And I would like to start out by saying I'm very disappointed that there is no patient on the panel. I think there should be. I have stage 3C heart failure with preserved ejection fraction, which was diagnosed 2 years ago in April. There are very few treatment options for patients with heart failure with preserved ejection fraction. In fact, 50% of us are dead within 5 years of diagnosis. I am by nature an independent, active woman. During my first year after diagnosis, I had numerous hospitalizations to try to control the aggressive symptoms of the disease, particularly pulmonary edema, which is the most frightening experience I've ever had in my life. For me, being hospitalized because of heart failure means not only stopping my active life, but also helplessly watching my loved ones give up their priorities, to take care and deal with the heartache of my fragility and my level of function decreasing and my dependence. My loved ones and I put other aspects of our lives on hold, passively relying on the hospital professionals to restore my level of function, or at least to stop my decline. Hospitalization moves me out of my community, insults my autonomy, and weakens my personal authority, in addition to causing physical weakness and subjecting me to possible infections. In April 2016, my physician implanted a pressure monitoring device in my pulmonary artery, which monitors me on a daily basis, allowing my physician to adjust my medications and activities before I am in acute crisis. Since the implantation, I have had no hospitalizations and am able to lead an active life. The heart failure has turned my life into having to take twice as long to do things half as well. But I am, thanks to my monitor, staying out of the hospital and being an active, engaged, contributing member of society. Thank you for your time, for your interest in heart failure patients, and for everything you're doing. And I'm happy to answer any questions you might have.
Thank you very much. I'd like to thank all of the speakers for their comments, and also invite all of you to take seats now in the front row, and we'll have an hour for Q&A from the panel. I will note that we are running ahead an hour, so we'll have this hour and then we'll break for lunch still at noon or slightly after noon. And it would be probably easiest if whoever has questions just turn your 10 card up and I will recognize you in order. And Dr. Okay, we'll wait, just give the panel a moment. Pardon?
Nicely managed, observing. Control, dignified.
Dr. Sheesh.
Yeah, my question actually is really... Say your name. Oh, my name is Eileen Sheesh. I'm from Cleveland Clinic, and I'm a heart failure transplant cardiologist. My question actually is really more for CMS. This was very interesting to me, but also very hard. I spent a lot of time thinking about the question, and I think we've heard some wonderful talks, and a lot of them reiterate some of the same things that were going through my head as well, that actually really the answers to the questions depend on the stage of the disease. Okay, so what, early versus late,
Also, the patient population, as an example, if you had all stage C and you had women versus men, one cohort is all women, one cohort is all men, the underlying disease is very different, okay? Their perception of symptoms may be different. There's some studies that say women have more symptoms, and yet survival is also different. So the patient population matters, and the therapy that we're trying to actually use really determines outcomes. So I almost wondered how we could fit one shoe for all of this, because I can create situations where outcomes depend on all these three factors.
Well,
Joshin
thanks.
is going to address it.
Thank you for that question. And also, it's a good point because I think we look at this with many of our decisions and many of the studies that we look at. So I think I would suggest and actually ask for input from the panel. I think I would suggest really approaching it from a standpoint of a broader, sort of population view. Whereas I think we know that, there are age and, patient characteristics, disease characteristics that would influence a particular, consideration. I think just looking at it more broadly from, a population standpoint may actually be one way to look at these questions. And I think that's the way we actually have considered it. And typically in our decisions, we will approach it that way. And I think if there are really some particular variables or criteria or patient criteria or specifications, we can make note of that. I think that's probably what I would suggest.
See, Julie, then Bram, then Art, and then Jody.
Julie Swain. I guess I'll question everyone here. We've seen a lot of mention here about 30-day endpoints, and we're talking about generally permanently implantable devices in chronic diseases. Can anyone justify, on this panel, on this group, justify a 30-day endpoint? Really? Because we know things like TEEs get done, swallowing dysfunction, aspiration, and having reviewed a lot of these patients when I was at the FDA, dying 3 months later in a ventilator unit. So tell me more about who thinks there should be a 30-day endpoint for any of this. Realizing, of course, that one TAVR valve in Europe got a CE mark on 78 patients followed for 30 days, and their TAVR was approved. But tell me more about justification for 30-day endpoints.
Yes, that'd be great, Chris. Thanks.
Chris O'Connor, great question, and I think that it depends, as Eileen said, on the disease state. If you're looking at a device in cardiogenic shock, which has a 50% mortality, it's perfectly appropriate to have 30 days as an endpoint.
Okay, anything other than absolutely end stage, going to die in the hospital, heart failure patients? Okay.
Thank you. Excellent question. Bram?
Just to perhaps reemphasize, the acute shock may not be an end stage. So those patients may be young individuals who may be salvageable, and thus there is the 50% survival. So I want to make sure that we acknowledge that.
Thank you. First of all, I'd like to thank all the speakers for some really great presentations this morning. My comments are directed more towards Dr. Adamson and Shaber. As we heard with Dr. Shee's comment, the spectrum of heart failure is extremely complex. One size doesn't fit all. And certainly one construct that I hope the panel will work with this afternoon is that provided in the central illustration of the Shaber panel of the Ferrara paper, or I believe it was slide 18 of Dr. Adamson's talk, where he talks about congruence of several intermediate endpoints, plus a trend towards improvement in mortality and reduction in hospitalizations. What's not clear in your talk, at least from the FDA perspective, is The requirement is that these studies are designed as adaptive Bayesian studies such that there's a numerical requirement for what type of probability we expect in the major endpoints when we, major morbidity endpoints when we see PMA submission, and that probability is expected to increase as the trial continues in a randomized fashion for eventual CMS submission. But be it as it may, Dr. Shaber, you talked about the use of several potential surrogates. The problems that we see in the heart failure world are as much methodological as choice of endpoints, in that, do you have any data on how any of those surrogates actually stack up when you use a quantitative criteria such as the Hughes criteria or the Prentice criteria? It's very easy to show correlations, but quantitatively, I think that we're in a very important quandary here.
So that was a very long question. In terms of, we've not done analyses in terms of correlation versus causation with those endpoints?
Let me make the question then more specific. For any potential putative surrogate, it's nice to show correlation, but the real challenge is to use the metrics developed for showing real surrogacy, which is a different standard using Hughes criteria, Prentice criteria, or really showing in actual clinical trials that the change in the putative surrogate really goes in a well-formalized relationship with the actual hard endpoint.
So we have done initial or additional analyses besides what I have shown there, not with those particular criteria, but looking at independence and direction, and looking at it as not just a cut point with medians, right, but across a spectrum of ranges, and they do move in the same direction across the entire spectrum of those endpoints. Considering left ventricular volume, for example, whether it's a 5% change, a 10% change, or a 15% change, those changes are all in magnitude. As the improvement increases in terms of left ventricular volume, the improvement increases in outcome in terms of reduction in heart failure hospitalization mortality.
Thank you.
I'll just add to that. I think it's an important question. And I'm thinking way back to when I was a cardiology fellow and we were still giving antiarrhythmics to suppress PVCs because we knew PVCs were a predictor of mortality and that people who had more of them did worse. But then the randomized controlled trial, which had mortality as an endpoint, showed there was actually increased mortality. So the surrogate was certainly decreased. There were less PVCs, but the problem was people were dying. Or maybe more recently, the Simplicity trial, which was a device thought to be beneficial on a intermediate outcome, didn't, well, that was sort of a sham control. So I think it's a question I'm sure we'll be coming back to. Next was Art.
Art Sidrakian from Walcoldnell Medicine. I would like to ask a question to Dr. Pina, and then others can also chime in about the rehospitalizations. And we all know rehospitalization is important to reduce, and it's a good endpoint, healthcare system efficiency question, aside from patient quality questions. But what I would like to learn from your personal experience and others, how manipulable is this endpoint in a clinical trial setting versus real-world evaluation of associations and reductions that we care about? Really, I mean, I don't want to mention a device, but it certainly created this whole change in our way we perceive a readmission, because it was possible, potentially, and potential bias of it, of seeing in a trial results. And related question to that is, what do you think about interventions that make physicians pay more attention to their patients, and as a result, they get reduced rehospitalizations? So it's two sides of the same thing, but I would like to hear your points, and also others if they can comment.
Thank you, and thank you for your question. I think it's right on the money. Certainly when we're doing a trial, we know what the endpoints are, and I do a lot of clinical trials, and we know that one of the endpoints is reduction in hospitalizations. And sure, it's really attractive to say, wait a minute, I don't want to put the patient in the hospital. Let me try this. You know, let me try to give the diuretic in the office, and let me try to bump up this medicine or maybe double this while I'm trying to get them out. And I really think it's in the eye of the beholder. Because if I see the patient, I can maybe stop the hospitalization, not just for the trial, because I don't think that some of those hospitalizations are good for the patient. And I think the patients do better not getting hospitalized. But somebody else who sees that patient may immediately say, oh, hospital. So whoever does that assessment is as critical as the assessment itself. Now, the other side of the coin is we know that if you follow patients closely, it can work. And so we have established and that we need to use our team members to work with us. We have data, and we have large data from Get With the Guidelines showing that if you get that patient in quickly for an appointment with whomever, and then we don't even classify how that appointment should be, that you can really reduce the rehospitalization rate. Whatever happens in that appointment, and in our post-discharge clinic, I've got a lot of different processes that happen, you know, including the assessment of quality of life. We get a pro-BMP, my little cubby holes. We try to fill in the cubby holes to see where the patient's going. And we have an 8% readmission rate from our post-discharge clinic. Earlier, the better. Physiology tells you that. So it's, again, that continuum of care, but your question is right on the money. I hope I answered some of it.
It's an important question.
State your name, please.
I'm John Carroll from the University of Colorado. And socioeconomic characteristics of patients, I think, have a major impact on rehospitalization. I do a mitral clip on a patient who's wealthy, who has an internist who comes to visit him home, has the resources, he has his own chef that has the right diet. It goes on, versus someone who doesn't have those resources, who may be less compliant. Boy, that makes a huge impact on rehospitalization rates, especially if it's an observational study. And I would choose study sites that had higher socioeconomic status of their patients if it was an observational. Brings out the importance of randomization to get rid of that factor, hopefully, but I think that this is a major modifier of what you were asking.
So John, just to clarify, Ken Artsedrakian from Weill Cornell Medicine, do you think the bias is bigger in observational context or in a trial context for measuring this rehospitalization when we're facing the bias of knowing what people get? I mean, you can just leave it as I don't know, but the question is, it's not really a trial design that can help with this because of blindness, because of inability to blind investigators and patients, whether the trial, in fact, might be more biased.
Well, I would respond, John Carroll, responding 2 points. Number one, randomization should help, but some people aren't entered into trials because they may be of a social economic group, they can't comply as well, et cetera. And so they're not included in trials that we will be treating those patients, and so we may be, have some artifacts produced from not having a broad spectrum of patients.
Right. And I think that seems to me a slightly separate point, because I think the issue of who does and doesn't get into trials is a little different than the issue of bias in a non-blinded trial when investigators are obviously invested in the trial, they're perhaps eager to see the treatment work, and then an endpoint like hospitalization, certainly, I think there's a lot of subjectivity. Some people admit people, some people don't. I mean, it is not by any means a hard endpoint. I actually think back to, it was more than 20 years ago when I was rounding in the CCU, and one of our fellows had just come back from a heart failure course that Lynn Warner Stevenson evidently taught. And she said, and we were admitting someone for what was then called dobutamine holiday. And she said, you said that we shouldn't be admitting people for a dobutamine, this is her quote, so you can say yes or no, for a dobutamine holiday, because you had all, it was like any kind of holiday, all the problems were waiting for you when you got home. And that really, we should be adjusting medicines and being more aggressive, PO, and, we didn't need to admit people. And I hope that's what you said, because I've taken it to heart, and I work very hard now, because I think people do prefer to stay home. But clearly there's a lot, I think there's, so that was how I took your question, Art, was that there is a lot of subjectivity. And in a non-blinded trial, when the investigator knows who's getting the treatment, there's a lot of, discretion into who you admit and who you don't admit. That's all. I'm going to try to move on because we have a lot more questions. I think next I had Dr. Siegel.
Thanks, Jody Siegel. I'm not sure who can best address this. So I'm wondering whether the outcomes that have been discussed would differ depending on if we're thinking about pre-approval trials, post-approval trials, or pragmatic trials, or if it's coverage with evidence development, or if it's just establishing outcomes for collection in a registry. Does that influence which outcomes are collected and chosen?
Beacon Boskert from Houston, a heart failure transplant physician, and I was representing the ACC. I think it's in line with the former statement of external validity or generalizability. If in the clinical trials the real population that we treat is included, then it wouldn't matter whether it's pre or post approval. Or in essence, the heart failure practitioners, when we end up treating more sicker patients and with a lot of more comorbidities, then it matters. So if the trial represents the real population, it may not.
Dr. Zuckerman.
Thank you. I actually have 3 questions, but I'll just do one now, and I'll wait my turn after. This is for the PCORI speakers, both of them actually, or either of them. One of the things that was striking to me about when you look at composite scores is that you're combining all these different things, and it's sort of the opposite of giving patients options about what's important to them and helping them decide, not just in trial design of what to study and what's important to them, but as they make treatment decisions, what's important to them. So I wondered if you had any thoughts about concerns about composite scores and what burden that puts on patients to not be able to make decisions that are true to their values or their concerns.
So thank you for that question. This is Larry Allen. I'm from Colorado and representing PCORI. I think that composite endpoints, like you mentioned, have advantages and disadvantages, and I think it depends on your perspective. We've talked about composite endpoints like mortality and hospitalization, and there's an advantage of putting those together because when people die, they may not be eligible any longer for a hospitalization endpoint, or it can be hard to follow forward what somebody's health status is if they're no longer able to fill out those questionnaires. So I think for one perspective, for dropout or for competing endpoints, it can be important when you're evaluating a therapy to think about the composites together. That's logical. The second is that I think if you're trying to decide whether something's medically reasonable or offers overall large benefit versus not, I think considering all the benefits together and the averages can be helpful to a payer like Medicare to say, we put all the benefits of this together, not just survival, but quality of life measures, whatever those may be that you decide are relevant with some of the other potential risks, and put that together. That can kind of help you to say whether this is something that offers relatively large value on average versus this doesn't seem to offer significant value relative to the costs and risks. And so I think when you're looking at it from that kind of global perspective to decide overall whether something is reasonable or not reasonable, I think the composite works well. On The flip side of it, I actually think that it's important from individual patient perspective to split them apart and offer them up to people to understand. So, so for instance, like I said, patients may have very different perspectives about what a gastrointestinal bleed or a stroke represents, and that could be true for lots of different kinds of endpoints. The other is, a lot of people have talked about the ranked endpoint, and I like the concept of a ranked endpoint where you take a group of people and you say, as a whole, which endpoint is more important than another endpoint. And I think that, again, can give you perspective about kind of the global value of something to decide yes or no, and whether that's reasonable from a payer or societal perspective. But I think when you go to the individual patient, ranked endpoints are extremely difficult for them to interpret and internalize. So I guess the answer is both. Yes, it's really helpful to collect all these pieces. From some perspectives, it's important to put them together and decide kind of a global summary value. But when you bring it back to patients, I think it's important to split them back apart, provide them in a way that people can then say, well, this is now covered by Medicare, or this is endorsed by some agency as being reasonable, but whether I want to do this for myself, I need to go back to the kind of individual pieces.
Thanks. Dr. Berliner.
Oh, no, he was the other. Yeah.
Bill Lawrence, Picorian. Just to add a little bit, it is sort of a trade-off in efficiency and trial design, of course, being able to combine the endpoints. But as Dr. Allen said, I think it's important to be able to have people understand at the end what the actual implications of the trial are, and that's something that actually should be piloted up front. But the ability to decompose the composite endpoints so that you can at least say, all right, here's the instance of stroke, here's the instance of fatal MI, et cetera, would be an important part in actually explaining the results to patients.
Yeah, just to ask a clarification, so I don't know if Picori's done this, but it occurs to me that, you know, when you have a composite score, tiny changes that aren't very meaningful to patients can add up. And so your score looks so much more impressive, but not much is happening. Whereas one bad thing can, you know, really affect a patient much more than all those little tiny good things, just as an example. And I just wondered if Picori or you have looked at that at all.
I would agree with you, but I don't know that we've done any formal work in the area.
Okay.
So, thank you.
Thank you.
Maybe someone knows, but I think I've read studies. The composite scores are generally driven by the weakest of the endpoints. You know, the softest, we would say, which are often hospitalizations or, you know, in PCI unstable, you know, anyway, revascularizations, things that tend to be a lot more soft or subjective. Dr. Berliner.
Hi, Elise Berliner. I have a question about the functional outcomes. So Dr. Allen showed that outcomes like the KCCQ and VO2 and 6-minute walk test were all following each other, correlated. And I noticed that in the slide that Dr. Caños showed about the ICHOM, that they actually are tracking functional outcomes with KCCQ, but then Dr. Bronner said that exercise measures such as VO2 outperform subjective measures such as KCCQ. So can you all help us understand that? So do you need to measure functional outcomes separately, or are they reflected in the KCCQ?
Ileana Pina is a clinician. In the KCCQ, remember, the KCCQ is not a quality of life instrument. It's a health status instrument, of which one of its domains is functional status. And for years, we've been trying to correlate peak VO2 and the functional status, and it's certainly not perfect. It gets close, but it's not perfect. But when you look at a list of prognostic variables, the most powerful prognosis of death is the peak VO2. Well done, a well-done test, and Dr. Sheesh has published on this as well as we have. So that functional assessment is way better if you can get the patient on the treadmill and you can do it. And I think that in centers like ours, we do that all the time. So the assessment by a questionnaire is an approximation, but it's certainly not perfect.
Dr. Stevenson.
Yes, I also want to thank the panelists for really thoughtful presentations. I want to go back to the hospitalization for a moment, and I think you did a really nice job of demonstrating how fast the background is changing in terms of these different ways to try to avoid hospitalization with IV diuretics or ED. In answer to his question, any one of those actually significantly increases the length of the workday for the person who plans it. So I think it's unlikely that they're going to admit people or give IV Lasix when they don't need to. One of the things, I think they're all important, as you demonstrated. However, clearly the severity of a patient who can have just an IV diuretic and go home is different than someone who has to spend 5 days in the hospital. So one of my questions is, do you think we could have a way of hierarchy there such that IV infusion is 1 day, ED is 2 days, at least in RED, and the hospitalization, however many days it is. So you're looking at a total of days that has some hierarchy there of the severity. That's one question. The other question is, do you think we can interpret that on its own, or do we need to make sure that any time we would use it, we would also compare it to total hospitalizations to make sure that there isn't something else that's increasing as we're decreasing heart failure hospitalizations?
Cam Boskert from Houston and representing ACC. The first question I think is, or suggestion is wonderful. I think, yes, we need to layer it like that, and I will perhaps add on to say IV diuretic in an urgent care or even a clinical setting, and then perhaps an OBS stay, and then the length of stay, because as in the administrator world, there are different things right now, and I think we need to be able to catch that. And then the second question, remind me, Lynn?
Total hospitalizations to make sure something else isn't
that
going on.
I think will differ according to the patient population and the device. If the device has a potential risk for bleeding, stroke, entities, the total hospitalizations matter. HFpEF, total hospitalizations matter because comorbidities matter. End of life, older, large, perhaps sicker populations where the comorbidities are the competing diagnoses, total hospitalizations matter. So I won't give a generic yes to that. Depends on the patient and the device.
Thank you.
Nancy Schweitzer from the University of Arizona. I would just add to that there are data to suggest that as we've reduced hospitalizations, hospitals with the shortest length of stay seem to treat a population with a higher mortality, and that we may be actually moving patients out of the hospital too early, and there's a significant cost to that. So I do think we have to always look at what's happening totally to the patient. And I can tell you at our hospital, if you're hospitalized on the hospitalist service, your length of stay for heart failure will be vastly shorter than if you're hospitalized on the cardiology service. So again, randomization is important. Having some control over where patients are in their care is very important, because a lot of these things are driven by things other than the severity of the heart failure.
Thank you. And maybe to state the obvious, but if a hospital had a high mortality rate, it would probably have a low rate of hospitalizations because dead people are not getting rehospitalized.
Censored.
Yeah. I would just note the speakers, if you just say your name, that's sufficient. It's just for the transcriptionists, and the MEDCAC panelists don't need to repeat your name because I'm calling on you by name. And Dr. Fish.
Yes, I'd like to get back to the issue of the composite endpoint. And I guess my starting point that I'd like to get your comments on is that CMS should value and pay for endpoints that are understandable to the public and patients, and not just understandable to clinical researchers or payers making complex decisions. And so I'd like some feedback on that position. But also for Dr. Allen, I wanted to ask, are there examples that you can see with doing decision aids with patients where you can use something like the CCS in a decision aid so that a patient's preferences can be realized?
Larry Allen, a good question. I'm not sure I have a good answer. I'm not sure that I've actually seen an exact CCS type rank score presented to patients, but Certainly when we use decision aids and option grids to kind of discuss different options, the different components of a score like that often are presented. And actually, the one that I showed you for left ventricular assist devices, we start out with what is the most important to most patients, which is survival, and then move to kind of what is quality of life, and then what are some of the individual components. So to some extent, we've tried to do that in the way that we've designed decision aids, and I think that the medical decision-making community has kind of moved towards in the way that they present. So to some extent, yeah, I think composites make sense, as I said before, in terms of trying to put value, trying to get a global value assessment, but the composites also presented to patients also allow them to kind of weigh all the different trade-offs and put them together as well. So to some extent, I think we do that both on the patient side and from kind of the global side.
Do you try to explain clinical trial data to individual patients by talking about the composite endpoints as a composite endpoint?
Yeah, so I do clinical care. I do spend a lot of time in clinic actually going through various options. And that exercise, I think, helps illustrate some of what we're grappling with today, which is that it's our job to really understand the nuances of trials and the different clinical courses that patients can have with the various options. But I think, one, the experience of doing that over and over and really listening to patients, but also having the help of a well-designed decision aid that has input from various stakeholders, not just patients and clinicians like me who kind of think they know a little bit what's important, but also to payers and other stakeholders like Medicare. To me, that all goes together. And I think composites do try and take the overall trade-offs, the global value, but they probably need to be combined in different ways, presented in different ways, depending on what the situation is that they're being used.
Yes.
I heard your question a little differently. Cynthia Chohan. I believe very, very strongly that clinical trial results should be accessible to patients, not just there on the paper, but understandable to patients. I believe patients should be included in the development of trials from the very beginning and should be viewed as participants, not subjects, so that when you come to the end, the language has to be meaningful to patients. And we are the final authority on our decision-making, I believe. And we can't do that decision-making without adequately translatable information from the trials.
Thank you. Dr. Hirsch.
Oh, thank you. Well, I want to ask kind of a methodologic question. All of us in the panel are grateful for the wonderful discussions by the presenters, but as we look at patient-focused outcomes as a really realistically important endpoint for trials and devices implanted for chronic diseases, I have a little bit of a worry. If I had a trial with a sample size adequate to show a series of patient-focused outcomes that were positive, how much do we know, about the robustness, generalizability, and durability of that over the lifetime of a device? In other words, in trials, again, like with hospitalization, we have a very specific, usually well-culled, well-represented cohort where people may feel better in downtown Chicago, Boston, and Philadelphia, but as I go to the Central Valley of California, Southern Illinois, rural Minnesota, it may be that those outcomes might not really be present or durable. I don't know who to present this to, Dr. Allen or one of the group. How do we know in the future that when Medicare provides us as a benefit that it will be generalizable and durable? Do we need to do post-marketing surveillance of patient-focused outcomes? How would that ever happen?
Well, Larry Allen, a couple of thoughts. A great question. The first, I just want to start off with somebody talked about subjective endpoints, and that was in reference to patient-reported outcomes. And I actually take a little bit of an issue with that. Sure. Whether I decide to admit somebody or how long I keep them before I discharge them, or whether I give them metolazone or IV Lasix in the clinic versus send them down to the emergency department, all of those things are somewhat subjective. Now, they correlate very well with other outcomes like death, which is certainly more objective. But I would be careful to say that a patient-reported outcome is somehow subjective in the way that you're defining it and lesser, as opposed to whether somebody gets a certain therapy that I may have control of. Now, your question was actually about the durability of, I think, patient-recorded outcomes over time and their generalizability across patient populations.
From a specific population to the American Medicare public.
Yeah, and I think some of it depends on the development and validation of the patient-reported outcome that you're looking at. So to some extent, I don't think you can group all PROs together and say that how they're going to perform and how well they apply to various groups. I think those people who know a lot more than I do about the development of PROs spend a lot of time looking at what is a clinically significant change to various populations. How does that correlate to other outcomes, and how durable is that over time? All of those things are part of the development process, and I would say I think you have to look at the various PROs to determine that. Other people know more than I do, though.
But as figures come up, do we know that we've actually had these patient-reported outcomes that really have been validated in the post-marketing environment, as we have for other endpoints? That's my question.
Nancy Schweitzer, speaking just to the KCCQ, which I spoke on, absolutely. It's been validated in many populations, men, women, all races across the country. In other countries, it's been translated into 80 languages at this point, I believe, and validated in many places in the world. It seems to be generalizable across heart failure populations. In a
trial settings, I'm aware that's true.
And outside of trial settings, yes, absolutely.
Right. What I thought you were getting at, Ellen, is that there's a difference between the trial populations, and Dr. Pina alluded to this in her talk, that are often enrolled in trials that go to FDA for drug and device approval, in that they're younger, they're more likely to be men, they're more likely to be white, and they're more likely to be healthier, because so many trials have comorbidities as an exclusion, and then therefore they're very hard to then generalize to a Medicare population, right, which is what we're talking about today, because those people are older, they're more likely to be women, more ethnically diverse, and they're more likely to have multiple comorbidities.
John Carroll, you're really making the case for clinical registries, post-approval studies, where it's a broader patient population, and you're able to get away from the more focused patient population and the treatment centers being very highly selected. And with the national coverage decisions that we've seen, it's been really a way to substantiate clinical trial results and further nuances of treatment, and to have enough data to individualize risk versus benefit rather than giving a global average of a trial.
I agree.
Thank you.
I will just say the issue with the registries is then there's no more control groups, so we have to have assumed that we've shown superiority compared to control, and then we're going to look at other populations. Do you want to comment briefly, because we have about 10 more questions.
Briefly, Dr. Hirsch, you're absolutely correct. It can be done on the outside, but the way that we have been using it for years is to categorize the patient. So you've got an ejection fraction, you have a peak VO2, and now you have a health status, and it gives you in your mind where that patient sits and how aggressive do you want to be. So it's not just did they respond to the treatment, but where are they at this point when I'm starting to take care of them.
Thanks. Dr. Saliv.
Oh, well, you almost stole my question, Dr. Redberg, but you gave me a great intro. I think I was going to ask about the generalizability as well, and I think, but from a slightly different point of view, which is the heart failure patients really have a lot of comorbid conditions, as you mentioned, and it's really almost universal and quite prominent. In spite of that, I think some of the commenters said that heart failure is dominant and we should only worry about that, is what I was hearing. But I tend to disagree, and except in, when it's very advanced, that definitely is true. But there can be dominance from cognitive impairment and dementia as comorbid conditions. I think some of the conditions have drug interactions and drug contraindications that become prominent. And so I think, this raises a lot of questions, I think, for that evidence development with, broader inclusion criteria for trials that we can, try to encourage that. I think FDA has done some work on that, to their credit. It also raises questions, I think, on the outcomes, which we're getting at
And I heard some commenters say that only disease-specific quality of life was useful. I disagree with that. And I want to know about generic quality of life measures, such as SF-12, Euroqual, PROMIS, which I think is heavily validated in some settings, but needs a little bit of work in the elderly. Generic quality of life, I think, can include safety. It's very broad. It can help with quality determinations, which some people are interested in. And so my question is, could generic quality of life be useful for, I think, communicating the risks and benefits to the patients? And so I guess my question is for Pecori or everyone.
Nancy Schweitzer. I'm not Pecori, but I was the quality of life person. We actually did a study comparing 5 generic quality of life study or questionnaires to KCCQ in a large heart failure population. And while all of the generic quality of life measures picked up the change that the KCCQ did so much more sensitively and with much larger confidence intervals, much smaller confidence intervals. And this was across a very large population that included many elderly patients, many with a great number of comorbidities. And this has been shown for KCCQ in multiple settings. So I think we are fortunate to have an incredibly well-validated disease-specific tool that's highly sensitive to changes in our patients. Now, in mild heart failure, where there's a severe comorbidity that's much more dominant, that may not be true for that individual patient. But in large populations of heart failure, KCCQ is as sensitive or more so than any more generalized quality of life tool that's been looked at. So I think that we are just in a very fortunate position, in particular with this survey.
Dr. Stevenson, to this point?
Quick comment, though, that sensitivity is not the only issue.
I just wanted to take that one more level because I think it's really important. Certainly, I think it's a well-validated tool in terms of heart failure, but when we looked, Eldrin Lewis actually studied this in about 750 non-trial patients. Only about half of the ambulatory heart failure patients said that heart failure was the major factor that limited their quality of life. So I think from a trial standpoint, it's very useful, but when we go to the patient and say, your quality of life is going to improve this often, we need to recognize that their quality of life may not have been limited by their heart failure. So I wonder if every time we're going to use that we also have the PROMIS or some other modern technological way of getting at this, so we can at least determine how often did overall quality of life improve when the heart failure quality of life improved, because that's going to be very important to some patients.
Exactly. Like if I have a patient that they're not limited by their angina, they're limited by the fact that they have arthritis in their hip, and they can't, fixing one isn't going to help them improve their functional status. I want to let Dr. Yancey ask a question, and I also just want to note that we have about 20 more minutes for the questions to the speakers, and then we're going to break for lunch. We have another hour for discussion amongst ourselves, so if any of you have questions that you think are more for ourselves and not for the speakers, maybe we could wait, because I certainly want everyone to be able. Great that everyone has questions, but I'm just watching the time. Dr. Yancey, and then we'll see if you had another comment.
Thank you, Dr. Redberg. I have questions for Dr. Schweitzer and Dr. Allen. Our task today is largely to look at outcomes that are absent the influence of mortality or absent the documentation of mortality. And it means that quality of life, once again, becomes very important in this discussion. I support the theme that's just been mentioned over the last minute, that the patient-reported outcomes measurement information system is a validated tool, particularly in the field of cancer and other chronic disease, that merits our further exploration. But I'm uniquely interested in a statement that you made, Nancy, and thank you for representing the American Heart Association's position, that the quality of life tool should be a separate assessment and not incorporated in a composite. And that would seem to lessen its influence, because there would be those that would not take it as generously as a standalone as opposed to being part of a composite. So both you and Larry can talk about the construct of a composite that includes quality of life, which I think is reasonable. I'd like for you to tell me why you think it should be separate, and Larry, if you can comment on that as well.
Nancy Schweitzer. Thank you, Clyde. Well, I think this gets to Dr. Redberg's point that when you have a composite and it's driven by the softest endpoint, that tends to cause a lot of consternation, and the quality of life is often considered the softest endpoint. I think that we all feel that how our patients feel is incredibly valuable, and I think it would be fine, as you know, Dr. Allen pointed out, you want to talk about the overall impact of a therapy on a patient, and quality of life can be taken into that overall impact and used as a composite. But I do think it's going to be important at the end of the day to separate quality of life outcomes out from other harder outcomes, just because, to be fair, regulatory bodies want to do that. You know, I think we could probably make a case for quality of life being an important part of composite, but I think the reality of the approval environment is that it's likely to dampen the enthusiasm for approval if an endpoint is seen as driven by that.
So, Dr. Redberg, as Dr. Allen's coming to the microphone, I think part of the frame shift that needs to go on in this discussion is to recognize the importance of quality of life parameters and not to allow the thought process to prevail that it's of lesser importance. And I think that, as Dr. Stevenson pointed out, there are more sophisticated instruments that can allow us to get much more specificity. And as Dr. Allen has already pointed out, hospitalization is an incredibly subjective income.
Right. I think that we have heard that consistently, and certainly I think my mission as a doctor is to help my patients either feel better and or live longer.
Yeah, I mean, I think I wouldn't call it a softer endpoint. What I would say is that quality of life questionnaires or health status measures, they happen in everybody who can answer them, and they are typically a continuous variable. And so consequently, you have lots of data to work with, and so relatively small changes can be picked up when you do an analysis, whereas an event like death is often more rare and is a yes or no, so the power to pick up the difference is less. So to some extent, I think that you know, when you combine these endpoints, some of them end up dominating over others, not because of which is more important or which is softer, but just by the very nature of the event and how you're measuring it. The other comparison I would make as people are going forward here, and this gets to the discussion of general health status measures like PROMIS or EuroQual or SF 12 or 36 versus a disease-specific measure, is a little bit like the argument that FDA and others and Dr. Zuckerman probably has a lot more to say on this, is between kind of all-cause death versus CV death, or all-cause hospitalization versus heart failure hospitalization. And I think it depends somewhat on your perspective. If you're trying to determine what's valuable to Medicare and patients, at the end of the day, if you prevent one kind of death but you increase another, that's not really a value. But over and over, when we try and design efficient trials that are able to look at differences, we have greater power to see important differences that are affected directly by the therapy and remove some of the noise and some of the other events. So to some extent, when I think about KCCQ versus measuring a more general measure, the general measures do have advantages. It's actually what's most important to patients, but I may have to design a larger study in order to show the difference in that, which may be fine, except that we also heard the argument stated earlier that requiring less sensitive endpoints that require bigger studies carried on for longer periods of time not only requires more costs on societies or whoever's running those trials, but it also leads to delayed approval of therapies that actually could be meaningful to patients. So, you know, everything's a trade-off, which I think I said earlier, and I think you all have to decide that. You know, if you're thinking about quality of life measures, which one you want to use depends a little bit on how important it is that you made a difference to the patient overall.
Dr. Zuckerman, did you want to comment on that?
Well, yeah, I mean, So about this KCCQ, I mean, it is a composite. It is a composite of functional and quality of life, and there's actually not that much that's quality of life. It asks, are you happy? It asks, are you depressed? It asks, are you able to do things you want to do, which can be functional or psychological. So it is a bit of a problem in terms of knowing what it really means, but I was struck in, I think, Dr. Schweitzer's PowerPoint that she talked about the placebo effect, and I think that's really important, not just for quality of life in the sense of how happy we are, but functional, that you need a control group and a well-controlled study, and you need to look at what's happening over time and whether the person feels like their functioning is better now because they were in the hospital having a procedure, and compared to that, they're doing really well. So I think there's a real problem with some of the data when we don't have a control group, we don't have a sense of compared to what, and not just compared to other people, but compared to, you know, how I'm thinking about how good I feel either psychologically or functionally.
Yes, okay. Dr. Sadrakian.
I just wanted to comment on the evolution of this disease-specific measures. Back 20 years ago when we started with SF-36, that was the only instrument available. 99, they used first time in cardiac valve patients, sent this questionnaire out because it was a popular way to measure quality of life, and no one was measuring cardiac valve population. And I brought these study results to Alvin Feinstein at Yale, who was running the RWJ program, and said, why do you need all these questions? Why don't you just ask patient transition questionnaire? One question, compared to before surgery, do you feel better today? That's trust your patient. They probably know best. You don't have to ask so many questions. But his point was, my answer was that I can't measure that. I can't run my logistic regression. My old regressions would fail. I need more questions. I need the continuous endpoint.
Okay, so I think you're saying shorter is better. But we'll take that.
But my point I'm trying to make,
shorter is better.
we abandoned the transition questionnaires and self-rated health questionnaires.
Thanks. Dr. Kobalars and then Addie Rambel.
Yeah,
And then
Fred Kobalars, and my question kind of builds on what we've been talking about with the KCCQ. You know, there's a long version. We've kind of discussed, you know, the domains. We talked a little bit about, you know, some of the limitations, and my initial question was, you know, had it been, you know, cross-validated in different populations, and you had answered that. But I guess someone had mentioned the whole cognitive impairment issue, and it seems to kind of be underappreciated. How is that being addressed in a self-administered survey? And are there, you know, any informant-based surveys that are out there that?
Nancy Schweitzer. Obviously, when cognitive impairment is significant, these surveys don't work. The KCCQ is all compared to 2 weeks ago, and if you cannot remember 2 weeks ago, you cannot do it. I don't know of any surveys for heart failure that can be used in a cognitively impaired population.
Much of what happens to the patients is not just cognitive impairment, they get depressed. So we have actually been giving the Beck Depression Inventory to the patients at the same time that we give them the KCCQ, because I think we're looking at two separate things. Cognitive impairment is really tough to get your hands around, and you think of, can you draw me a clock? You know, can you tell me what you had for breakfast this morning? Maybe some of us can't remember. But that's the kind of questions that we would have to integrate into a format. And I think we need badly something like that. And it may have to be the caregiver that answers the questions if the patients can't.
And that's, I mean, and I wasn't referring to the more, you know, advanced, you know, cognitively impaired individual. It's the MCI folks, the early dementia that, you know, nobody asks that, you know, how's the memory? And, you know, we go on to administer these surveys, but, you know, are they truthfully, you know, answering these, you know, questions, and, you know, how valid is that information?
Okay, Addie Rambel.
Thank you, Dr. Redberg, and thank you to the speakers this morning. The presentations were excellent. My question, and really it's probably more of a clarification, is that we talked about the patient journey at the beginning and patients who start out as stable and ambulatory before essentially their first hospitalization, but they proceed to decompensate as they go along, but without some sort of signs or symptoms of that. So it seems that if we're able to measure how quickly they're decompensating before that admission, then we could perhaps that's a predictive measure, I don't know. But what I'm not sure I heard is, how is that measured today?
This is Phil Adamson from Abbott. Very good question. And the data set that has been built over years has come from implantable monitoring technology, both from therapy delivery devices that provide diagnostics, like CRT devices and ICDs, that have led to the evolution of implantable devices for monitoring pulmonary artery pressures. And in trials in which pulmonary artery pressures have been measured, those pressures change long before patients develop symptoms, and if they go unchecked or untreated, they lead eventually to the development of symptoms, but that symptom development is late in the progression to congestion and hospitalization. So currently, implantable monitoring systems are the way we are able to gain insight to provide the provider and the patient information about their transition from ambulatory hemodynamically stable to this pre-congestion or pre-symptomatic congestion phase.
Is there any data linking pre-congestion to survival?
The only data would be to look at, actually there is. There's a recent article that's a retrospective evaluation of the chronicle experience many years ago, published in Circ Heart Failure by Dr. Zeil and his colleagues and Dr. Stevenson. And essentially, for every 1 to 2 millimeter of mercury reduction in pulmonary artery pressures over time, there's a long-term benefit in terms of survival. Survival is directly impacted by elevations in those pressures from baseline to 6 months as well. So what that study demonstrated is similar to what we see with systemic hypertension trials. A 5 millimeter of mercury reduction in systemic blood pressure, diastolic blood pressure is associated with 41% reduction in long-term risk of stroke. So we see that now that we have sort of a blood pressure cuff of the pulmonary artery, we see similar type behavior of pulmonary artery pressures by actively lowering them and keeping them from going into that pre-symptomatic congestion phase.
Thank you. Dr. Swain.
Yeah, I just want to talk a little more about the placebo effect. The problem we have in virtually all these trials is it's impossible to blind them. And you can have a blinded patient, but if you don't have a blinded treating physician, I'm convinced that the patient will end up knowing the results. And we have several studies over the years that have told us all about this, from knee arthroscopy to migraine treatment with, needles, to the PMR, percutaneous myocardial revascularization, holes in the heart with a laser. And, in the PMR study, the treatment group improved 2 classes of angina in like 41% of the patients. And in the placebo group, 41% of the patients. And I'd urge you all to read Kapchuk's literature from Harvard, that the placebo effect is proportional to ritual, how much you do to a patient, and is proportional and is very long lasting. So for many years at the FDA, I couldn't interpret them. I looked at them, but it did not involve my regulatory recommendation because I have absolutely no way to figure out what any of these patient-reported outcomes mean. And for those of us old enough to remember the red SIBO caps, the big red pills, the placebo pills for patients that you wanted to cut down, amazing results with that. So I don't like to call them soft outcomes because the most important thing is how the patient feels. But I don't know how to measure it in an unblinded trial.
Right. I think that's a really important point, and we know that's even more powerful for procedures and devices than it is for drugs. And you're right. I mean, that's important. People feel better, but if you can feel better from a placebo, then why have the harm of an invasive procedure or intervention?
John Carroll, I think that's an excellent point, and that's why you have to have different domains of outcomes. So if you're changing some anatomy, some physiologic variable, you have to show that the device actually does that, and then does it correlate with patient-reported outcomes. Things like migraine are difficult because there's no objective assessment of migraine, so it's a totally subjective report. But most of what we talk about, there are objective measures.
Probably not always. And Ileana's point is about who gives the test. TVT registry, it's the treating physicians that mark down, you're doing better, aren't you? And so the patients are doing better. So it's a huge problem of how we measure it.
Right, and it's definitely not blinded. I mean, I took your point to mean that it has to actually be double-blinded and, with a sham procedure, because we know that, even for the neurosurgical procedures for Parkinson's, I mean, there was a sham surgical procedure, and it found those people who got a sham hole in their skull did as well. They improved their Parkinson's.
Oh, and we have PET scan evidence that giving a placebo or doing a placebo changes the brain just like something that would be beneficial, like a narcotic. So it is physiological. When we say it's in the patient's head, it actually is neurologically in the patient's head, and there's a physiological, anatomical reason that placebos work.
So Dr. Hirschnose, we'll come back to this after lunch.
All I'm going to say, Julie, is I think it's very important for the panel to come back to this after the break and after lunch and really dig into this, because as we expedite approvals with 21st century cures, we change levels of evidence, and we have opportunity costs of what we know and what we don't know. We'll have to accelerate comparative effectiveness research. The dollars for devices would be dollars for a single nurse or belief system when we want to provide beneficiaries. Let's come back to that.
Dr. Berliner, you'll get the last question before lunch.
I get the last question. My question is, only Dr. Schweitzer, I heard, mention clinically significant difference. So I'm wondering, for all of the intermediate outcomes and things like exercise tests, do we have a minimally clinically significant difference? Do we know what that is? And also, just back to my question before about some of these things that are correlated, sort of, but not quite, like KCCSQ. If we wanted to have like a core outcome measure set that was measured in all studies, but not being duplicative or undue burden, like what would that core measure set look like?
Right, so it's a perfect segue. I was just commenting to Larry about this. Ileana Pina. When we started using the KCCQ, we had the Minnesota Living with Heart Failure questionnaire, and we had been told that a 5-point difference was clinically significant. And so we were asking the question, what should it be for the KCCQ? And that 5-point has been derived from a group of us it was called the Quality Outcomes Group, where we said, 5 sounds good. And then we sat there and we did 6-minute walk, we did BMP, and we did repeated testing in a group of our own patients in the clinic. And that's how we came up with the 5. When we did HF Action, it was a 2-point difference that became statistically significant, but we had 2,331 patients. For peak VO2, if you look at the literature, about a 15% increment is what we consider clinically significant from baseline. In other words, the patient's own improvement. When you compare these group to groups, you're comparing apples and oranges. So I like to look at the patient's own improvement. And 15%, Clinton, wouldn't you say, I think is what's recognized in the literature as being functionally significant, that it takes you to another level of your function in your daily life. For the 6-minute walk, I think that's still out unless anybody has 50, 54, we've said 54, 55.
Thank you. Well, we clearly going to have a rousing discussion after lunch as well, but right now we get to take an hour. So we'll come back at 1:10 and we'll have panel discussion. Thank you all. And thank the speakers again for really giving us a lot to talk about.